and see what rhythm your patient's in. You can't do all that as a BLS provider.
It feels like there are openings in the heart which literally don't exist. I thank you,
that was a lot to say, but you must resume CPR immediately to so keep your hands on the chest until someone with more experience tells you to stop.
Thank you so much.
18. What is the correct depth of chest compression for a child? Is it A, at least 2.5 inches, B, at least 1/3 the AP, which stands for anterior posterior diameter of the chest, which is about 2 inches or 5 centimeters? Would it be C, approximately 1.5 inches or 4 centimeters, or D, only 1 inch? And if you're enjoying this practice test and you haven't liked the video or subscribed to our channels, please go ahead and do so. We appreciate you.
In the right ovary there. So this patient,
adult CPR and child CPR have many similarities. And one of the similarities is going to be the depth. So the answer is B. Yes, it's still 1/3.
Then you see,
or
on ultrasound, you can see that there's an early pregnancy there,
2 inches. So that is the correct standard for or older. And what we like to say for the ranges for a child would be age to a stage. It would be from 1 to puberty. And puberty would be signs of adulthood, such as breast development, or if you have a very large child who is an adult weight and adult height, you're going to go ahead and treat them like an adult regardless.
Can cause a lot of
Question 19. For an unresponsive infant with a severe airway obstruction, what is the correct action? A, blind finger sweep.
So you can see this is the fetus
B, 5 back blows and 5 chest thrusts.
You can see there's a heart.
C, abdominal thrust. Or D, start CPR immediately.
Closed. The cervix is very intact.
We have an unresponsive infant with a severe airway obstruction.
Very beautiful.
They choke.
Early pregnancy. However, the culprit is this one.
Here's your hint so you can rethink your answer.
Such configuration.
Anytime a choking victim becomes unresponsive,
with the pregnancy, make sure that you also
we are always going to do D, whether it's an adult, child, or an infant. If a choking victim becomes unresponsive, we're starting CPR.
Heterotopic pregnancy. So
you can check the airway to see if you can see the object that's in their airway
you also have to check
before you give a breath. And if you can see the object, you can remove it by doing a finger sweep. We are not supposed to do blind finger sweeps. So if you can see it, you can remove it.
Simple cyst there.
20. Where should AED pads be placed on a child if the pads risk touching each other?
So there's no sonography.
A, side by side on the chest. B, on the stomach and leg. C, anterior, posterior, front and back. Or D, do not use the AED.
Also to check if there are no other masses, no other obstacles. The uterus
revealing the correct response in 3, 2, and the answer is C, yes. So placing one pad on the center of the chest and one pad on the center of the back ensures the correct pass, the current passes through the heart without the pads touching.
So
and here's the illustration.
This is very, very
so
critical.
Center front and center back.
How ultrasound is the greatest.
Question 21. You are a lone rescuer or a single rescuer
because
finding an unresponsive infant who is not breathing.
Very difficult to know
the collapse was not witnessed.
Of the pain.
What should you do? A, call 911 immediately. B, find an AED first. C, perform 2 minutes of CPR and then call 911. Or D, wait for help.
Must be competent. You have the skills, know where to look and know what to look for. So if you know that,
revealing the correct response in 3, 2, and
we only don't
yes,
check for
it is C. So whenever you have an unwitnessed arrest of a child,
does not exist in isolation.
You perform 2 minutes of high quality CPR first to get blood flowing to the brain. So the care first principle applies here. Oxygenate the blood before leaving to call for help.
You also have to check
if it's unwitnessed and it's a child, 2 minutes of CPR first, a child or an infant. 2 minutes of CPR first, and then go call 911. And that's assuming you don't have anyone there to call 911 for you, or that you don't have your cell phone readily available where you can just dial and put 911 on speakerphone.
Within them. Or
question 22. What is the correct hand placement for abdominal thrust, previously referred to as the Heimlich maneuver, on an adult? Is it A, mid-abdomen, just above the navel?
Tubes are not visible.
B, on the sternum? C, below the navel? Or D, on the rib cage?
So the other thing that you must also have to check is the nature and the structure of the uterus itself.
Yes, everyone answered it correctly. It is A, mid-abdomen, just above the navel. And so the rationale, the fist is placed against the abdomen, in the middle, slightly above the navel, and well below the breastbone. And you would do those upward thrusts. If you don't have anyone to assist you and you're choking and you're by yourself, you can put your abdomen against a chair, something that's sturdy enough to support your weight, like a table, or even the edge of a sofa. And you would thrust your body into that object to help relieve or remove your own obstruction.
And then the miscarriages are coming.
Question 23.
So it is
when performing back mask ventilation, how do you determine if the ventilation is effective? A, the stomach rises visibly. B, you hear air escaping.
Ladies and gentlemen,
C, the oxygen saturation reads 100%. Or D, visible chest rise.
So we must understand that when you're doing a pregnancy scan, we are not just ignoring the gynecological ultrasound.
You are such a wonderful caregiver. Yes, the answer is D. Seeing the chest rise with each breath is the primary confirmation for effective tidal volume. And that's about half the squeeze of the air, of the back mask device. So half squeeze should result in visible chest rise. If you see the stomach rise and fall, that means that you are given too much breath, and as a result, your patient could vomit.
Don't forget to subscribe, to share.
24. Which of the following team roles is responsible for recording the time of interventions and medication administration? Is it A, team leader, B, timer recorder, C, compressor, or D, airway?
Detailed scan that is done, or the anatomy scan that is done mostly or traditionally from 20 to 23 weeks of pregnancy. Some, they do it from 18 weeks to 23 weeks during that period.
The correct response is B, the timer/recorder. And so this designated role tracks time intervals such as switches, and also what medications are administered, and it records events such as when the shots are administered.
How it is done.
25.
So
what is the maximum interruption time allowed for chest compressions during things like pulse checks or AED analysis? Is it A, 30 seconds, B, 5 seconds, C, 10 seconds, or D, 1 minute?
The black one is the water or the amniotic fluid around the baby. So what we have here, that's the placenta there. So you can see the legs of the baby, they are crossing each other there. And you can see the foot there. You can see the tib and
if you chose C, you're absolutely correct.
The knee joint.
The goal is to keep the chest compression fraction, or CCF, high, which means that interruption should be limited to less than 10 seconds.
That's the heart. This is the heart.
Question 26. What is the correct rescue breathing rate for a child or infant with a pulse?
Then you can
is it A, 1 breath every 6 seconds?
The baby's moving.
B, 1 breath every 10 seconds?
And it's moving.
C, continuous breaths? Or D, 1 breath every 2 to 3 seconds?
Nicely demonstrated there. You can see the movements of the fetus.
All right. I see a lot of answers in the chat.
See the heart. That's the heart there. You can see here, that's the stomach bulb with the black spot there. That we
if you selected D, you are correct. You're going to give 1 breath every 2 to 3 seconds because children have faster metabolic rates and require 20 to 30 breaths per minute. And the way I like to think of it is who breathes the fastest? An infant breathes the fastest. So for an infant, if you are allowed to, based upon your protocol in your hospital, it would be 1 breath every 2 seconds. But let's say you have a school ager. You have a child who's a little bit older. Well, that would be the person you give a breath one every 3 seconds. But follow your medical director's guidelines.
So you can see
Question 27. You are using a bag mask device. Which technique is recommended for holding the mask in place as a SEMO rescuer? Is it A, two-hand palm technique, B, C-clamp technique, also referred to as EC clamp, C, O-clamp or O-grip, and then D, press down hard on the nose?
You can see how it is moving. So you can actually see that
what is the correct technique when you are holding the bag mask device, the mask portion in place?
You can see the eyes of the baby there. The eyes of the baby.
That is right. It is B, the EC clamp technique.
So you can see
the thumb and index finger form a C on the mask, and remaining fingers form an E on the jaw.
Those are the ends. This is spinal cord.
Question 28. If a victim has a pacemaker, a visible lump with a scar on the chest, where should you place the AED pads? A, directly over the pacemaker. B, only on the back. C, do not use the AED. Or D, at least 1 inch away from the pacemaker.
It's a male, it's a boy. That's how we determine the fetal gender. So you can nicely see it in the second trimester like that.
If you chose D, you're absolutely correct. You're going to avoid placing pads directly over the device. You're going to remove the pad slightly to one side of the device or below it.
So this is the cerebellum.
Question 29. Why is hyperventilation, giving too many breaths, harmful during CPR? A, it increases intrathoracic pressure, thus decreasing venous return to the heart. B, it increases oxygen too much. C, it causes the lungs to burst. Or D, it wakes the patient up.
You can see nicely there. And then if we come again
Why
here,
do we want to avoid hyperventilation? That's right, it is A. High pressure in the chest collapses the veins, returning blood to the heart, thus reducing the effectiveness of compressions. So too much of a good thing becomes a bad thing.
Come again, this is the transverse section
30.
Of the
what is
abdomen.
The first step in using an AED?
Fetal stomach.
Is it A, applying the pads, B, plugging the connector, C, power on the AED, or D, shout clear?
So I think it's making sense. These 3 dots there, that's the spinal cord in transverse, like we're cutting it.
No, it's not D, everybody. It is C. You're going to power on the AED. And some of them, as soon as you open up the case, it automatically starts talking to you. So you have to know how to use the AED at your location. It's usually as simple as 1, 2, 3.
So that's the heart.
And they are so user-friendly until if it does have an on button, it's green, which means go. So it's time to go. We have to save this patient's life. So turning on the AED activates the voice prompts that guide you through the rest.
Those are the landmarks that we use to
31. In a team setting, what should you do if you notice the compressor is not allowing full chest recoil? A, wait until the next switch to tell them. B, push them out of the way. C, constructively correct them immediately. D, ignore it.
No sonographic sign of hydrocephalus. So if we
your team members not performing CPR correctly, they're not allowing full chest recoil.
So the baby
what do you do? That's right. We're going to continue working together as a team. You're not going to push them out of the way. That's rude. It's going to be C.
So you can see now.
Effective team dynamics require constructive intervention to ensure high-quality CPR. And the American Heart Association has a role that is referred to as the CPR coach. And the CPR coach would be the person who is monitoring the quality of the CPR. And if you don't have that person, it is expected that during CPR, that someone is going to be monitoring the quality so that we can make sure that we are doing our best efforts to save this patient's life.
You can see
32. What is the correct depth of compressions for an infant? Is it A, 2 inches, B, 0.5 inches, C, until you feel resistance, or D, approximately 1.5 inches?
The organs to see if everything is developed well. So it's an extra effort that he has to take.
Revealing the correct response in 3, 2, and it is D. 1.5 inches or approximately 1/3 the chest depth is the specific depth for infants. 33. You are performing CPR on a victim who has been submerged in water. What should you do before applying AED pads? A. Remove the victim's wet clothes completely.
So you see the
B.
hand
Dry
now.
the victim's chest.
The end there,
C. No special attention is needed. D. Wait for the victim to dry naturally.
And there are 5. So you see them again. See them again. See them again.
The answer is B. Dry the victim's chest. And so the American Heart Association, according to their 2025 guidelines update, they have recognized that due to cultural differences, some rescuers may feel uncomfortable touching a woman's chest, exposing a woman's chest, etc. And so what that means is that research has indicated that women are less likely to survive cardiac arrest events that happen outside of a hospital because of the chest factor. Male rescuers, if you feel uncomfortable touching the chest, exposing the chest, keep doing those high-quality chest compressions. If there's a woman nearby or someone who feels comfortable exposing the chest and drawing the chest, please allow them to take over and do so. So American Heart Association has their guidelines, but as a basic life support provider, my expectation of you is that you're going to do everything to save that woman's life. Of course, you have 911 on the phone. They're going to ask if you have an AED, and if you have one, use it, because women are more likely to die from sudden cardiac arrest if it happens outside of a hospital because of the breast factor. Okay, so let's get over that. We want you to do everything to save a woman's life the same way you save a man's life.
So here you can see how the baby is moving.
34. According to the 2025 guidelines, how should you position your hands for adult chest compressions? A, 2 hands centered on the upper half of the sternum.
See, this is
B, on the left side of the chest. C, over the xiphoid process. D, 2 hands centered on the lower half of the sternum.
The hip bones, the placenta on color Doppler there.
And we're going all the way to question 50.
And the baby or the fetus.
The answer is D. So we're going to avoid the upper half of the sternum. It's going to be the lower half. This position places the force directly over the ventricles or the bottom part of the heart for maximum cardiac output.
This is the uterine artery. That's how we measure the right uterine artery.
A victim becomes unresponsive while you are performing abdominal thrust for choking. What is your first action? A, check for a pulse.
This is the other one.
B, continue abdominal thrust. C, begin chest compressions. D, open the airway and look for the object.
Like that. This is the bladder or the baby there. That's the bladder of the mother, sorry. So, ladies and gentlemen,
the answer is C. If a choking victim goes unconscious, lower them to the ground and start CPR immediately. Do not check for a pulse.
Gestational age of 21 weeks and 4 days.
Question 36. When should you deliver shocks from the AED?
November,
A, immediately upon arrival. B, if the victim has no pulse, regardless of AED prompt. C, only when the AED prompts shock advised. D, after 5 cycles of CPR, regardless of analysis.
Thank you so much. So we now have a playlist in our channel, which we call the pregnancy level.
That is right. So it is C. You cannot deliver a shock unless the machine, the AED, identifies a shockable rhythm, such as V-fib, which would be VF, or pulseless V-tac, and charges.
Lifeline of the fetus.
So the shock would not be automatic. It will let you know that a shock is advised. It'll let you know that it's charging. And then you as the rescuer would have to press the button that delivers the charge. And of course, before you press that button, the word that you're going to shout out would be clear. Make sure that no one is touching the victim, including yourself, because that way it keeps everyone safe and it prevents someone who has a normal perfusing pulse from getting shocked and their heart now changing into a non-perfusing
sure that the baby is
rhythm.
alive, and also there are no
37.
obvious structural
Which
abnormalities
cardiac
that can
arrest
either
rhythm
the
is
pregnancy or the
non-shockable?
preparation. So here
Is
we
it
put
A,
the heart there.
asystole,
So that's the
B,
fetal heart.
ventricular
You can see here.
fibrillation,
You can see the fetal
C,
heart.
ventricular tachycardia pulseless.
This is the left ventricle.
Or D, atrial fibrillation.
You can see the right ventricle there. So
and I know those are some big terms, but I already told you his answer. So I know you're going to get it right.
Perform a very good
which cardiac arrest rhythm is non-shockable?
Or echo. So you can see here. You can
That's
see the
right,
there.
the flat line. Okay, D is not a cardiac arrest rhythm. D, atrial fibrillation would be a perfusing rhythm. So we're not going to shock a perfusing rhythm unless it's like super fast or super slow. So for this one, the correct response is going to be A.
Shunts.
Asystole or flat line represents no electrical activity. Shocking, it does nothing. CPR is the treatment.
You can see the arc of the aorta.
38. How do you perform chest thrust on a responsive infant with a severe airway obstruction? A, with the heel of one hand in the center of the chest. B, using both thumbs. C, you should use abdominal thrust instead. D, with 2 fingers just below the nipple line.
So ideally, when you're doing a fetal heart or a fetal echo, you must make sure that you zoom the image so that you can.
And this one reflects the 2025 American Heart Association Guidelines update. The answer is not D. The answer is A. With the heel of one hand in the center of the chest. Remember, we're not using the 2 fingers anymore on infants. Infants with severe foreign body airway obstruction, you'll do repeated cycles of 5 back blows. So back blows first, and then alternate with 5 chest thrusts. We don't perform abdominal thrusts, and we're no longer using the 2-finger technique on infants because it was not deemed to be effective.
It's localized within the chest in the
39. What is the best way to open the airway of a victim with no suspected neck injury? A is jaw thrust. B is head tilt only. C is chin lift only. D is head tilt followed by chin lift.
Localizing anatomy formulas one of the fundamental skills.
Yes, the answer is D. This maneuvers the tongue away from the back of the throat.
When you want to be a competent sonographer or someone who can be confident in your practice.
Question 40.
So,
in a 2 rescuer CPR, what is the role of the second rescuer while the first is doing compressions?
You can zoom your heart
A,
nicely,
check the pulse continually. B, maintain the airway and provide ventilation.
Remember,
C, rest.
Measuring the heart is
D,
not
monitor the feet.
Because we are looking at 2 moving targets that you have to beat. The fetus will be moving.
If you selected B, you're absolutely correct.
So you must be very vigilant.
The second rescuer manages the head/airway and delivers breaths during the pauses.
Obvious pathologies of the heart. Also, during
Question 41. Which of the following indicates a victim has a severe airway obstruction? A, they can speak and cough forcefully. B, they are wheezing loudly. C, they cannot speak, breathe, or cough effectively. D, they are crying.
That I was talking about.
We give you about 3 seconds to enter your responses in the chat.
Be very careful because it is very easy.
And you have it. It is C. So silent cough, inability to speak, and cyanosis or turning blue are signs of severe obstruction requiring immediate intervention.
And you can
42. When checking for breathing, what are you looking for? A, pulse rate. B, eye movement. C, chest rise and fall. Or D, skin color.
That you can use. You have a good resolution machine. Zoom the target area.
Yes, when you're checking for breathing, you are looking for C, chest rise and fall. You're going to scan the chest for 5 to 10 seconds.
I hope
43. What is an agonal breath? Is it A, infrequent gasping breaths? B, rapid deep breathing? C, whistling sounds? Or D, normal sleep breathing?
Or you have got a machine that you don't trust. Because some people, they fight their own machines. If you don't trust
I see
your
we're
own
torn
machine,
with our responses in the chat.
It is very
So agonal breathing would be A.
that you
Agonal
can
gasps
consult me,
are a sign
and I'll show
of
you
cardiac
how
arrest
to best
and should not be confused with
utilize your
normal
machine to
breathing.
get the
You're
best
going to start CPR.
results.
So you go in and you tap and you shout.
I
You're
hope
tapping on your patient's or your
you are
resident's
learning.
shoulders. There's
I hope
no response.
you are taking
Immediately
notes.
call for help.
So let's meet again
Press the cold button,
in
scream
the
for the nurse.
next
And now for
episode
the
of
next
our
10
learning series.
seconds, 5
Thank
if
you so
you're a
much.
more experienced healthcare worker, but 10 if you're a little novice or new. You're going to put 2 fingers on the carotid pulse on the side nearest you. You're going to be feeling for the pulse while simultaneously watching for chest rise and fall. You do not feel a pulse, but your patient lets out a gasp.
People of the internet, gather
No
here.
more breaths.
Now,
No other signs of
I'm going to
life.
show you
That is a precursor of cardiac arrest. You scream for that AED and you start doing your compressions. So again, agonal gasp or agonal breathing, person letting out their last bit of air, that would be a sign of cardiac arrest, and you should not confuse that with normal breathing. Remember, there was no signs of life and you did not feel a pulse.
How it appear like
44. For a child victim, if you do not have pediatric AED pads, what should you do? A, do not use the AED. B, cut the adult pads in half. C, perform only breaths. Or D, use adult pads.
You can see the balls there. You can see the balls there. Those are the balls there. These are the fetal bumps. The fetal bumps.
Yeah, this one's tricky. I agree.
The testicles there. The testicles. So this is the septum.
But it's not tricky for you all. We're going to use the adult pads. The answer is D. The rationale is better to use adult pads, which will deliver a higher shock than no shock at all. And whenever we are, thinking that those pads are going to touch, we don't use the pad placement that's on the pads. Instead, we're going to put one pad in the center front of the chest and then one pad in the center of the back, as illustrated in the image there. And that prevents the pads from touching. You can use an adult AED on all ages, adults, children, and infants. However, you cannot use a pediatric AED or the pediatric pads on an adult. If you don't have adult pads or if you don't have the AED, remember what we're going to keep doing. We're going to keep focusing on CAB. We're going back to those compressions and focusing on circulation.
You can see the spine.
45. Closed loop communication involves A, shouting orders loudly. B, repeating the order back to the team leader. C, using hand signals. Or D, only the lead speaking. Or only the leader speaking.
Very excited. So
closed loop communication.
The gender, you see here, 1, 2D. That's the penis there.
Yep, you got it. We're going to repeat those orders back. Now, look at this team, and it's a rescue team, and they're trying to save a life. And now, it could be really loud. It could be chaotic. There could be 10 people in the room. I need to know you're speaking to me. So you're going to point to me. If you can't see my badge because maybe I have on PPE, you're going to point to me and you're going to say, hey, you, because you may not know my name, you are going to do the first round of compressions. And I'm going to repeat it back to you. I have the first round of compressions. So the receiver repeats the order to confirm it was heard and understood correctly. That is how we close the communication loop.
As a practitioner is when you
46. Which link in the chain of survival is the most critical for survival from ventricular fibrillation? Is it A, advanced life support, B, post-cardiac arrest care, C, rapid defibrillation, or D, recovery?
Or they discredit your practice.
And I know we discussed a lot, but I told you this
you must make sure that
section.
You do your homework.
What do we do for VFib?
Before you
I see you changing your answers. Yes, for VFib, we defib. So the answer is C, rapid defibrillation. Defibrillation is the only effective treatment for ventricular fibrillation. Time to shock is the biggest predictor of survival. So we need to get that AED on the scene and on that patient as quickly as possible.
And finally, the
47. How deep should chest compressions be for an adult? You know this. We've already talked about it. Is it A, B, C, or D?
This is the 8th boy. We've been trying to make a girl ever since. So
I know I put centimeters first.
Gender reveal.
And yes, if you chose B, you are right. At least 5 centimeters or 2 inches up to 2.4 inches. That is the standard adult depth for chest compressions. 48. What is the ratio of back blows to abdominal thrust in the 2025 adult choking protocol? Is it 3 to 1, 5 to 5, 15 to 2, or no back blows, only thrust?
Development, or in terms of building your own reputation.
Or D.
We have got reputations to protect as practitioners.
That's right. It is B, 5 to 5. 5 back blows followed by 5 abdominal thrusts.
I want you to look here, guys. You see this one?
49. You're responding to a pregnant woman in cardiac arrest. An AED becomes available. What is the correct course of action regarding the use of the AED? A, do not use the AED as the shock will harm the fetus. B, wait for the advanced life support ALS team to arrive before defibrillating. C, use the AED but reduce the energy dose by half. D, use the AED immediately and follow standard steps.
So I need you guys to do due diligence when it comes to fetal gender determination.
The answer to 49 will be revealed in 3, 2,
that and can actually destroy
the answer is D. Use the AED immediately and follow the steps of the AED.
For the rest
Here's
of your
a
career.
rationale. The best way to save the baby is to save the mother. Defibrillation is safe and effective in pregnancy. The best hope for fetal survival is maternal survival. Use the AED as you would for any adult cardiac arrest victim.
The gender, and they made me
50.
to buy the
If you're too tired to continue high-quality CPR and no one else is available, what happens?
Take your time.
A, stop immediately. B, continue at a slower rate. C, the AED will take over compressions. Or D, the patient's chance of survival drops significantly.
This is continuation of a fetal anomaly scan. If you
You're getting tired. You're by yourself. No one has come yet. What's going to happen?
And then
you all the answer is D. The chance of survival is going to drop significantly. This is the reality. You're going to get tired, okay? You're going to become fatigued. That is why as soon as you find someone who's unresponsive, somebody who doesn't have a pulse, they're not breathing, you're calling for help immediately. The person who comes to assist you, let's say you're in a home care setting, the person who assists you doesn't have to be certified in CPR. It would be nice if they were.
I need you guys to take this seriously.
The door, they can, call 911. If they're strong enough, they can even take over the chest compressions to give you a moment to get a break.
I thank you very much.
Remember, this is a team effort, and so you can only do so much by yourself. So you're going to be calling or activating EMS as soon as you can, and you're also going to utilize any bystanders who are in the area who can assist you. And guess what, team? I am so proud of you. You have completed a full 50-question CPR/BLS review and practice test. If you are interested in becoming an instructor, if you want to learn more about the classes we offer at Florida Training Academy, go ahead and scan the QR code that's on the screen. And then if you want to support us further, don't forget that, yes, I'm an author. And so I have a new CNA exam prep study guide, which can be purchased directly on our website or on Amazon by scanning the QR code that you see there. Thank you for watching. It has been a pleasure helping you review and prepare for your basic life support class. And if there's anything we can do for you at Florida Training Academy, don't hesitate to reach out. We appreciate you. We wish you much success on your career endeavors. Have a great day.
Then we are going to have what is called the brain sparing effect.
Hey, everybody. Welcome back. This is Nurse Eunice with Florida Training Academy. And you are absolutely correct. I have an updated 2025 CPR/BLS practice test just for you. It has 35 practice questions with real-life scenarios designed to help you pass your CPR and AED and or your basic life support examination. So as we do in each of our videos, we're going to give you a few moments to receive your notifications and then get your pen and your paper, and let's pass our exams together. So, hi, everybody.
Of life.
All right, so what's the purpose of this video? So whether you're taking the American Heart Association, an American Red Cross, or an Health and Safety Institute BLS or CPR class, this video is for you. How is that? Because all of the brands of CPR gather their data based off of international standards. So this is shared knowledge, just packaged a little differently based on the brand of course that you actually attend. And so the information I'm telling you is going to be good nationally because it's based off of international standards. So it doesn't matter if I'm in Florida, I'm still going to help you pass your examination. How? By reviewing real life-saving skills like CPR, AED use, how to perform CPR on a pregnant mother, rescue, breathing, etc. I'm going to test your knowledge of team dynamics and emergency response and get you prepared for real-world scenarios. That's right. I just don't want you being able to pass a test. I need for you to pass the exam, and then if one of your patients has a cardiac emergency, I need you to know what to do, and I want you to feel comfortable and confident. And so here, we don't use fear tactics. I want you to be able to learn CPR and be comfortable, because if you're comfortable, you will speak up and you will let someone know if you need help. And that's the purpose of BLS. So CPR, think individual, layperson, single rescuer. When you think basic life support, think of you have a full team. And so if you get tired, if you need advice, if you need help, you have a supportive team there who's going to help you do whatever you can in order to save a patient's life. So great job, team. Whether you're a healthcare provider, a nursing student, or if you just need a quick refresher, this video is for you. And we also have a free library with CPR, BLS, ACLS, PALS, and CPR instructor resources, free videos on our YouTube channel. That is youtube.com/Florida Training. We also have our all disciplines American Heart Association classes right here in Florida. Our website is fltraining.com. And if you need free study guides, you know Nurse Eunice has you. Whether it's CPR, EKG, ACLS, you're going to go to nurseeunice.com. Again, I'm just not here to help you pass a test. I am here to make sure that you are a confident and a safe caregiver who knows how to respond if there is an emergency with your patient. Let's begin. As I read through these questions, if you don't already have paper and pen, pause the video, get paper and pen, and then come back. And then, because I don't want this video being too long, I'm going to reveal the rationale, the answer, in a 3 to 5 seconds. So if you need more time than that to process, to really think about the question, pause the video. All right, so question 1. What is the recommended rate for chest compressions for adults during CPR? Would it be 60 to 80 compressions per minute, 80 to 100 compressions per minute, 100 to 120 compressions per minute, or 120 up to 140 compressions per minute? I know that was a mouthful. All right, revealing the answer in 3, 2, and you are correct if you chose C. So the American Heart Association recommends a compression rate of 100 up to 120 compressions per minute for effective perfusion. Question 2, what is the correct compression depth for an adult victim? In other words, how deeply do you compress? Is it A, about 1 inch, B, at least 2 inches, C, about 3 inches, or D, no more than 1.5 inches? Do you know the compression depth for an adult victim? And if you chose B, you certainly do. So adult chest compression should be at least 2 inches or 5 centimeters, but no more than 2.4 inches deep. 2 inches or 5 centimeters. All right, question 3. Which action is the first step in the chain of survival? Is it A, early CPR, B, advanced life support, C, rapid defibrillation, or D, activation of the emergency response system?
Of this very critical landmark. So I've done this presentation.
Revealing the answer in 5,
to show you how you can
4, 3, 2, and if you chose D, you have it. So the first link in the adult chain of survival is number 1, recognizing cardiac arrest, recognizing when a person is pulseless and not breathing. And then secondly, we'll be activating EMS, the emergency medical services. And so whenever you watch some of the videos, they don't say call 911. They don't say call a code. Instead, they're going to say EMS because they don't know where you work. If you're inside of a hospital, you are 911 until the rapid response team gets there. So you're going to call a code. You begin your chest compressions, and when your other team members come around, they will then start taking over the care. If you're in a home care setting or in a clinic, well, you more than likely will have to call 911 because we have to get that person to a hospital in case they need additional services. So that is the difference. That's why in your video, it doesn't always say call 911. It says, hey, you, go get help, come back, activate EMS or call EMS. Question 4. When giving compressions to an infant, which is the correct depth? Is it A, a quarter of an inch, B, 1 inch, C, at least 1.5 inches, or D, at least 2 inches?
So, echogenic fetal bow is in.
Right, revealing the correct response in 5, 4, 3, 2, and if you chose C, great job, team. For infants, compression should be at least 1.5 inches or 4 centimeters deep, or about 1/3 the depth of the chest. Question 5. How often should you switch roles during to rescue or CPR? Would you switch A, every 2 minutes, B, every 5 minutes, C, after 10 cycles, or D, only when exhausted?
Infection that is taking place like a congenital systemic.
All right, revealing the answer in 5, 4, 3, 2. Yes, it is A. So even if you don't feel exhausted, if you are doing things according to the American Heart Association, the American Red Cross guidelines, you're going to be switching every 2 minutes. So if you have help, switch, because switching helps prevent fatigue and it maintains high quality compressions. Question 6. What is the compression to ventilation ratio for one rescuer adult CPR? Would it be A, 15 compressions to 2 breaths, B, 5 compressions to 1 breath, C, 30 compressions to 2 breaths, or D, 20 compressions to 1 breath? So that's a ratio. It's 15 to 2, 5 to 1, 30 to 2, or 20 to 1.
So
all right, put those thinking caps on, revealing the answer in 3, 2, and yes, it is 30 to 2. It is C. So for adults, a ratio of 30 to 2 is standard when performing CPR alone. So single rescuer, 30 compressions followed by 2 breaths. And if you need this in writing, you all, we have free study guides. Go to nurseunits.com and download your free study guide today. Question 7. When should the rescuer initially ensure the scene is safe? Is it A, after assessing the victim, B, after calling 911, C, upon arrival at the scene, or D, after delivering the first breath?
Look at it, that item there.
When should the rescuer initially ensure that the scene is safe? And if you said C, all right, you are correct, because before we even provide care, we have to make sure that it's safe for us to be there. So scene safety is always the first step before approaching the victim. If the scene is unsafe, you will not approach. You will call 911 from a safe distance. You matter also, so do not try to render aid if there's a possibility that you yourself can get hurt. Question 8. What is the most reliable method to confirm effective rescue breaths? Is it A, watching for chest rise, B, listening for breathing, C, checking the carotid pulse, or D, using a pulse oximeter? All right, revealing the correct response in 5.
So if you rush this
2, and 1. The most reliable method for confirming effective rescue breaths is A, watching for visible chest rise. If you don't see the chest rising, you're going to reposition and reattempt, but at no point should it take you longer than 10 seconds to administer 2 breaths. If it takes longer than that, worry about them after you go back to your 30 compressions.
Ladies and gentlemen, when you're doing this,
Question 9. Which victim requires only rescue breathing and not compressions? Is it A, an adult who is gasping? B, a victim with a pulse but no breathing? C, a victim who collapsed suddenly? Or D, an infant with no signs of life? And let's read that question again. Which victim requires only rescue breathing and not compressions?
If you see like this, it looks like it's coming from the fetal brain there. Look at
this one's a little trickier, so we'll reveal the answer in 5 additional seconds.
You can nicely see that it's originating from the placenta.
And if you chose B, you have it. So B is the correct response. If they have a pulse but they are not breathing, you're going to supplement their oxygen by giving rescue breaths. You would not be giving rescue breaths to someone who's gasping. Maybe they need an asthma treatment, maybe something else is going on with them, but they're gasping. So even though it may be a partial obstruction, they are still breathing at this point. So right now, that would not be the correct response. You would not be providing rescue breaths to someone who is gasping. You would monitor them and notify the physician. Question 10. What is the correct hand placement for adult chest compressions? Is it A, one hand over the abdomen, B, one hand in the center of the chest, C, 2 hands on the upper abdomen, or D, 2 hands on the lower half of the sternum?
To look at a lot of issues. You must
reveal the answer in 3, 2, and it is D. So hands should be placed on the lower half of the sternum while avoiding that very bony end, the xiphoid process. And I know a lot of you, especially if you've been taking CPR a long time, you like to try to measure the intercostal spaces. Remember, most adults are too fluffy. You can't feel my ribs. So I like to say, just imagine that the person has a perfect nipple line, even if the breasts are pendulous and hanging. Once that chest is exposed, put your hands in the lower center of their chest and start doing your compressions without trying to measure the 5th intercostal space. Great question 11. What should be done immediately after the AED delivers a shock? Is it A, wait for the AED to reanalyze, B, check for a pulse, C, resume CPR, or D, deliver rescue breaths?
Initially, when I saw this, I was thinking that maybe it's a encephalocele, but after due diligence,
so after the AED delivers a shock, you're going to do C. So there is no residual charge. You put your hands back on that chest and you start resuming high-quality CPR. So it is C, resume CPR immediately after shock delivery without checking the pulse. Remember, the AED will be analyzing the rhythm every 2 minutes. So it's going to let you know to take your hands off so it can reanalyze. And that kind of takes away the need for a pulse check until the advanced providers come along. Excuse me for clearing my throat. Question 12. For an adult, how often should rescue breaths be given if they have a pulse but no breathing? So they have a pulse, but they're not breathing. We know we're going to give rescue breaths, but how frequently? Is it A, every 5 to 6 seconds, B, every 6 seconds, C, every 10 to 12 seconds, or D, every 15 to 20 seconds? And I know with this one, you're torn between A and B, but according to the current standards, it is B. A is the old standard. So now, for an adult victim, you give a breath every 6 seconds. You'll provide 1 rescue breath. So again, according to the current American Heart Association guidelines, provide 1 breath every 6 seconds for an adult with a pulse who is not breathing. Question 13. When should rescuers switch roles in 2-person infant CPR? Is it A, every 3 minutes, B, after each AED shock, C, after every 2 minutes, or D, after 15 compressions?
This one is a
All right, revealing the answer in 3, 2, and you all, regardless of the age, you are switching compressors every 2 minutes, whether it's an adult, child, or infant. And remember, I have a video on YouTube that is an actual video refresher of me performing adult, child, and infant CPR. You can refresh yourself in less than 20 minutes. And the video link is down below. All right, so question 14. What is the preferred method or technique for giving compressions to an infant with 2 rescuers? Is it A, one hand technique, B, 2 thumb encircling hands, C, the heel of one hand, or D, 2 finger technique?
The man of God said. So now, let's review the agenda together. And then you can
the preferred technique, if there are 2 rescuers with an infant, is going to be B, the 2 thumb encircling hand technique. The way I like to think of this, because we know that children and infants, if they go into cardiac arrest, more than likely it was their airway. Well, this way we give the respiratory therapist the airway. They can manage the airway. If they need to intubate, they need to trach, we're not blocking them. So you, as the compressor, you take the lower half of the infant, and that allows the respiratory therapist to monitor, to manage the airway. So the 2 thumb encircling hand technique provides better depth and consistency, and it also allows respiratory therapists to do what they do and manage their airway without you being so close to them. All right, so that is the position if there are 2 rescuers for infant CPR. Question 15. What is the recommended compression to ventilation ratio for 2 rescuer infant CPR? Is it 30-2, 15-2, 5-1, or 20-1?
This is one of
the
those
compression
cases.
to ventilation ratio for 2 rescuer infant CPR.
Look at that. This is a
all right, revealing the answer in 3, 2, and the correct answer is B, 2 rescuer CPR for infants and children. Uses a ratio of 15 compressions to 2 breaths. Let's think about the reason that a child or an infant goes into cardiac arrest. I just stated it. It's usually because of airway. Maybe they drown, maybe they asphyxiated, maybe they had an asthma attack, anaphylaxis, but right now we need to supplement their oxygenation. We have to give them more breaths. And so when you switch to a ratio of 15-2, within the same 2-minute window, remember we switch every 2 minutes, you end up giving double the breaths. So with 30-2, you only give 10 breaths. When you switch to 15-2, you're giving closer to 20 breaths, and that's going to help provide the extra oxygenation that a child or an infant needs. Don't forget, they also breathe faster than adults, so we need to give them oxygen more frequently, or breaths more frequently. Question 16. How soon should CPR be started after recognizing cardiac arrest? So we tap and we shout, hey, are you okay? Are you okay? No response. We're going to activate EMS. We're going to call the code. We're going to pull out our phone, call 911. We're going to feel for the carotid pulse. We're also going to be checking for breathing. How long should all of that take? Is it A, within 30 seconds, B, within 1 minute, C, within 10 seconds, or D, after calling 911?
It's a girl.
So once you realize this person is pulseless,
it's a boy, as you can see there.
How long do you have before you start your high-quality chest compressions?
If you were in my shoes,
and if you said 10 seconds, ding, 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 you are an awesome caregiver. It is C. So high-quality CPR should begin within 10 seconds to improve survival chances.
Was I going to say
Question 17. When using a bag mask device, how many rescuers are preferred? So think hypothetical. Think that you have a full medical team. How many people do you want using the bag mask device? Is it A, 4, B, 3, C, 2, or D, 1?
They wanted to give the men of God.
All right, revealing the answer in 3, 2, and it is C. There are 2 rescuers. So one is going to maintain the seal, and then one's going to squeeze the bag.
Attributes that we need.
And then I can't give you any more information, because if I do, I'll be giving away a future test answer. All right, question 18. If a choking victim becomes unresponsive, what is the next step? That's right, because BLS not only covers chest compressions for all ages, so CPR for all ages, it also covers how to handle choking emergencies. So if a choking victim becomes unresponsive, what do you do after that? Would it be A, begin CPR starting with compressions, B, continue the abdominal thrust, C, check the airway, or D, deliver 2 rescue breaths?
Competent somebody, or they will see that this person is a robot or doesn't know what he's doing. Understand?
We're revealing the answer in 3, 2, and whenever a victim becomes unresponsive,
in the country
you want to start CPR immediately. So the answer is A. And whenever you begin CPR, remember we begin with chest compressions. Whenever you go to give the breaths, you can look for the obstructing object. If you see it, you can remove it, but it's going to be chest compressions first.
To me, it was more.
Question 19. What action is part of high-performance team dynamics? What action is part of us working together during a high-performance team activity, such as a code? Would it be A, ignoring roles, B, closed-loop communication, C, acting independently, or D, all rescuers doing compressions?
But you know what? I had to do
and this may be a new term for you all, so I want you to make sure you write this term down.
We explain that this is
the only option here that is a part of high-performance team dynamics would be B, closed-loop communication, verbalizing what you heard. And so I love this image. And so let's say this is one of our doctors who has a strong accent. And this patient who's in cardiac arrest was on contact isolation. So in addition to having an accent that can sometimes be hard to understand, we also have on full PPE, including mask. So I can't read his lips. So I want to make sure that if he gives me an order, I repeat it back to him. I'm closing the communication loop. And so closed loop communication ensures orders are understood and confirmed. Question 20. What should you do if the AED says no shock advised? Is it A, resume chest compressions, B, remove the AED, C, check the pulse for 30 seconds, or D, deliver a rescue breath?
Hello everyone, how are you doing? Here we've got a case in a first trimester.
And I want you to think about this. Why would the AED say no shock advised? Has the person achieved ROSC? Do they now have a pulse?
So what we have here,
or is the patient now in asystole, which is a non-shockable rhythm? So when the AED says no shock advised, don't get tricked. Resume CPR. It is a great job. All right. And even if the person did have a pulse, right now the pulse could be 10, it could be 20. Because remember, we don't, whenever it already did the pulse check. And so once it did the pulse check or the check for the rhythm, it said no shock advised. Go ahead and start CPR. All right, keep starting your CPR. Resume it because if it does not advise a shock and there are no obvious signs of life, such as a person moving, you're seeing chest rise, it could be that a person went into a more lethal arrhythmia, that they're now in asystole, which is non-shockable. Question 21. What is the proper compression technique for a child using... What is the proper compression technique for a child if there's only one rescuer? I want to make sure that I reread that one. What is the proper compression technique for a child if there's only one rescuer? Is it A, 2 fingers, B, 2 thumbs, C, 1 hand or 2 hands depending on the child's size, or D, the heel of 1 hand only? And the child is from 1 to puberty, age 1 to puberty. So if the young girl, if she has breast bud development, we consider her an adult. So this is somebody who has not reached puberty. Would you use 2 hands, 2 fingers, 2 thumbs, 1 hand, 2 hands, or just the heel of your hand? It's going to be C. For a child, use 1 or 2 hands based on the child's size to ensure proper depth. Something that I like to add, especially if you don't have the upper body strength, is if you only use one hand and that child doesn't make it, for the rest of your life, you're going to be stuck with thinking, could I have done more? So unless it is a really small child, I recommend that you use two hands. You're not going to compress too deeply. Most laypersons and most novice professionals, they don't compress deeply enough, which is why whenever you take your CPR classes, your mannequins, your devices have to have feedback devices that click light so that you understand how deeply you have to compress. And for a child, you're still compressing 2 inches or 1/3 the depth of the chest. 22. What is the correct sequence of steps in adult BLS? Is it A, airway breathing compressions, B, breathing compressions AED, C, compressions, airway and breathing, or D, AED, compressions and breathing? And that's a lot, so I'm going to give you about 10 seconds to read through that.
So it's too early now.
And if you understand the current guidelines, which have been in effect now for about 10 years, you understand that the correct sequence of steps in adult BLS is CAB. It is CAB, compression, airway, and breathing. So if your patient's in cardiac arrest, your focus is on high quality chest compressions. If you're a single rescuer and they vomit, what do? Do you turn them to the side? Or do you keep doing your chest compressions? Remember, your priority is CAB, CAB. If you take your hands off the chest to turn them to the side, what happens to the blood flow to the brain? It stops. They're going to be brain dead. So you keep doing your compressions. You can turn their head, try to sweep out their mouth within the 10 seconds. But if they get vomitous in their lungs, we call that pneumonia. We can treat that with time, intubation, antibiotics. You take your hands off the chest and you stop blood flow to the brain. That's brain death. We can't reverse that. So until your team arrives, it is C, compressions. Once your team arrives, they can then help and focus on the airway and the breathing. Your team will be bringing a crash cart. They'll also be bringing the first aid equipment. And so you just keep compressing. If you don't know what else to do, keep compressing until someone tells you to do otherwise. I love this image. This is one of our CPR classes. When I say CPR, I mean an American Heart Association basic life support. So these are our professional rescuers. And so we are worth the drive or the flight. You can look at our class schedules at fellowtraining.com. We need at least one day. Like we literally will have you attend your instructor course in the morning and then have your monitoring session in the evening. You're going to have a long day, but when you leave, you are going to feel knowledgeable, empowered, and more than that, you're going to be certified. And so if you're interested, go to our website. Question 23. What is the purpose of defibrillation? A, it starts a stopped heart. B, it delivers medication. C, it increases oxygen to the brain. Or D, it stops an abnormal rhythm.
On the kidneys in the babies too.
What is the purpose of defibrillation?
But if there was hydronephrosis,
revealing the answer in 3, 2, and I know this one was tricky, and I know you wanted to choose A. But what if the person was in a systole, and that was the cause of their stopped heart? So the purpose of defibrillation isn't to start a stopped heart because it can't fix everything. But it would be D. The goal would be to hopefully, let's give you the correct answer, to stop the abnormal rhythm. So defibrillation stops fibrillation, such as VFib, ventricular fibrillation, to allow the heart to reset and beat effectively. Now we're going to question 24. When should the AED pads be removed? Is it A, after CPR, B, once a pulse is detected, C, when instructed by EMS, or D, never during a resuscitation effort?
The heart rate looks fine.
All right.
There are no issues with the heart.
I think everyone has their answers now, so we're going to responses. And 3, 2, and 1. You all will never take off your AED pad. So the answer is D, during a resuscitation effort. And so even if the person regains consciousness, if they achieve ROSC, We just don't turn off the AED and take off the pads, because when you hear us say we coded a person 3 times, that means that we got a pulse and we lost it again. We got a pulse and then we lost it again, because we never went to the H's and T's that advanced that ACLS part. So we don't know what's wrong with them that keeps causing them to go into ventricular fibrillation. And so don't turn your AED off. The advanced professionals, once we have that patient stabilized, will let you know when to turn off the AED. All right, you all. Question 25. What is the recommended compression to breath ratio for 2 rescuer adult CPR? So we covered 1 rescuer adult. We covered 2 rescuer infant. And so now we're on 2 rescuer adult CPR. It's you and your CNA in the room. What is the ratio? Is it A, 15-2? B, 20-1, C, 30-2, or D, 5-1?
If you've got other differential diagnosis, please do share with us.
We're revealing the answer in 3, 2,
and also I appreciate
you all for adults, regardless of the number of rescuers, up until the point where they're intubated. It is going to be 30-2.
Share with us.
So the answer is C. If there are 8 people at the bedside, if that person's not intubated and they're an adult, it is still 30 compressions followed by 2 breaths. And so our little table over here on the side kind of gives a breakdown. So for adults
pregnancy,
with 2 rescuers, it's going to be 30-2. However, for children and infants with 2 rescuers, because we have enough people to give more breaths, it is going to be 15-2. And remember the logic behind it, because we're giving closer to 20 breaths per minute for our children and infants versus for adults, they're only going to get about 10 breaths per minute. So the compression ventilation ratio changes when performing CPR if you have 2 rescuers for children and adults only. For children and infants only. For adults, it will remain 30-2. Question 26, and we're going all the way to question 35. What is the main goal of effective team dynamics during a resuscitation attempt? Is it A, allowing multiple leaders to contribute, B, enhancing efficiency and minimizing interruptions, C, ensuring tasks are performed independently, or D, assigning 1 person to monitor oxygen saturation? What is the goal of working as a team during a code?
Look at the foot there. So this was it.
Ding, 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 ding. We need to minimize interruptions. We got to keep our hands on that chest. The answer is B. So 80% of the time, you want to be doing chest compressions. We call that chest compression fraction. So something I like to say, which may be inappropriate to some of you all, but I like to say we don't stare at dead people. We're compressing, or we're feeling for a pulse, or we're using the AED, but your hand's just coming off the chest. No. Good team dynamics ensure coordinated care, minimize interruptions, keep those interruptions no more than 10 seconds, and that is how we improve our resuscitation outcomes. Question 27. Which of the following best distinguishes cardiac arrest from a heart attack? Is it A, a heart attack always results in loss of consciousness? B, cardiac arrest involves a sudden loss of heart function and pulse? C, chest pain is never present in cardiac arrest? Or D, a heart attack always requires defibrillation?
So what I wanted to demonstrate...
and because this one is so lengthy, I'll give you about 10 seconds to read everything again.
Pregnancy. If these fibroids are too big, they compete for space with the growing or the developing embryo.
We're going to correct response in 3, 2,
Look at the foot.
You all, it is B. So I like to think of the heart as a house. A house has plumbing and it has electricity. When you think of a heart attack, think of plumbing. The plumbing has gotten backed up. And so this person needs angioplasty. He has to go in and clean out that artery. So they're still talking to you, but they have chest pain, difficulty breathing, they're nauseated, they could be lightheaded. If they're a woman, they may not have any of those symptoms. They may have back pain. And so women usually have atypical symptoms if they're having a heart attack. Regardless, let the doctor know, get an EKG. Heart attack, they're still talking to you. Meanwhile, cardiac arrest, that's the electrical part of the house. When the electricity goes out, that patient collapses. They're on the ground, unresponsive, no pulse, no breathing. So cardiac arrest is more severe. Cardiac arrest is unconsciousness, unresponsiveness, and absent or abnormal breathing. And so that is going to be the difference between the two. Cardiac arrest requires CPR versus a heart attack. It may require hospitalization, some anticoagulation, or some blood thinners, and also a trip to the cath lab. Or if it's really severe, they may need open heart surgery. But they're still alive, they can talk, and they can live to tell their story. If we don't perform CPR properly and someone's in cardiac arrest, they're going to have worse outcomes. Question 28. Why is allowing full chest recoil important during compressions? And so allowing full chest recoil, does it A, increase oxygenation, B, help to prevent rib fractures, C, allow the heart time to refill with blood, or D, does it avoid respiratory fatigue?
Most women,
why allow the chest to recoil to return to its normal position?
Of these fibroids, and they can become a problem when they get pregnant. Like
revealing the answer in 3, 2, and
complaining of pain.
It is C. If you always have pressure on the chest, if you never allow it to recoil, remember every time you compress, you're squeezing the blood out of the heart into the circulation. So we're allowing it to circulate to the heart, the lungs, and then when you allow it to recoil, when you allow the chest to expand again, you're allowing the heart to fill back up with blood. So if you're compressing really, really fast, if you're going above 120 compressions per minute, you're doing a lot of work, but inside of their body, their heart doesn't have as much blood flow. So you're supposed to let that chest rise all the way and then compress down again so it's filled with blood, so we will have better perfusion.
Tolerate the pain.
Question 29. When administering intranasal Narcan or naloxone during suspected opioid overdose, which is true? A, one spray is administered in one nostril. B, it should be administered directly into the mouth. C, it should be only given if the patient is conscious. Or D, it replaces the need for rescue breathing.
If you comment, you...
And yes, as a BLS provider, you can administer intranasal Narcan. We are Narcan providers. We have the Narcan trainers, but you have to come to our office in order to receive your Narcan. So if you're in the Jacksonville, Florida area and you would like Narcan for free, just let us know. We'll have a few boxes available for you. We can do your training in about 5 minutes, and we can provide you with Narcan so you can help save others. And so everybody, the answer to question 29 is A. So intranasal, inside the nose, intranasal Narcan is of course administered via the nose, and it's usually one spray. So each of those doses, or each of those nasal containers, it just has one dose of medication, and most of your packaging comes with 2 different dosages. And so remember, you're going to do our tap and our shout. This person's still breathing. If they're not breathing, you cannot use intranasal Narcan. If they're not breathing, keep doing your CPR. And when EMS arrives, they can start an IV, and they can give intravenous Narcan if they suspect an opioid overdose. So for you as a BLS provider, they still have to be breathing in order for you to administer intranasal Narcan. And then you want to stimulate them, rub on their chest, do that sternal rub. You can turn them to the side. There's a possibility they're going to vomit. Remember, you can turn this person to the side because they're still breathing, their heart's still beating. The opioids, it suppresses their respiration. And so when you give the Narcan, it's going to bind those opioids up. Talk to your provider, talk to your instructor about it, talk to your teacher about it. One thing they don't really tell you that you may not be prepared for is when they do wake up after you have given them Narcan, they don't wake up nice and happy. You just bound up their drugs. So you want to be very careful. And if at any point you have to use Narcan, you need to be calling 911. They need to be en route because, again, if this person goes into cardiac arrest, they may need intravenous Narcan, not intranasal. Question 30. An AED becomes available while you are performing CPR on a pregnant woman. What should you do? A, delay defibrillation due to pregnancy. B, continue CPR, but do not use the AED. C, use the AED as you would on any adult. Or D, turn the woman on her left side before using the AED.
The questions which are following.
So yes, the American Heart Association, they do have guidelines on how to perform AED use on the pregnant mother And the correct response is going to be C. You're going to use that AED on mom. And I know some of you are thinking like, oh my God, I'm going to shock the baby. But right now, mom's heart is just fibrillating. It's not contracting. So there's no blood flow to the baby. Mom is dead. The baby is dying. Mom's in cardiac arrest. The baby is dying. We want you to use the AED to hopefully restore mom's heart rhythm, to get her out of ventricular fibrillation, to get her pulse, her heart beating again, so we can help save the life of the baby. And so research has indicated that AED use is safe and appropriate in pregnancy, because saving the mom's life is top priority if we want to save the baby's life. Question 31. Which of the following is a contraindication to using an AED? Is it A, the patient is on a metal surface? B, the patient has a DNR or do not resuscitate order? C, the patient is pregnant? Or D, the patient has an implanted pacemaker?
15 millimeters C, 25 millimeters, then D.
Which is a contraindication? I know this one's hard,
Question
right?
number 3.
The answer is
but no cardiac activity is
B. If someone has a do not resuscitate order, we're not performing those life-saving interventions like defibrillation. And so it's actually a misconception to think that you cannot use an AED on a metal surface, because according to the American Heart Association guidelines, metal surfaces pose no shock hazard to either the victim or the rescuer. And then in addition, in cases that involve water, let's say drowning incidents, you can still use the AED if a person is drowned. You just have to remove them from the freestanding water and only dry off their chest before using the AED. And I think the other one was an implanted pacemaker. And so usually your doctors are so smart, they put the pacemakers on the left side. And so your AED pad goes on the right. And so you can still use your AED if a person has an implanted device. You just cannot put your pads directly on top of the implanted device. And so that is why the latter was not a true contraindication either. Question 32, going all the way to 35. If you have liked this video, if you learned something, put what you learned in the chat and give us a thumbs up. We are so close to having 1 million subscribers on YouTube, and we couldn't do it without you. So thank you all for letting me be your online nurse educator. Question 32, during a resuscitation attempt, the team leader assigns roles and uses closed loop communication. What is an example of closed loop communication? A, everyone start CPR. B, can someone get the airway? D, give 1 milligram epinephrine IV now, and then followed by a repeat, the person saying epinephrine given 1 milligram IV. Or is it D, just do whatever you can?
Question number 6.
All right, so we know it's not D. And I know you remember my scenario from earlier. So closed loop communication means that we close communication gap. And so it's going to be C. If you tell me to give 1 milligram of IV epinephrine, I'm going to let you know once it's been given. I should not take any more tasks until I do the first task. So that is how we close the loop. We confirm and we repeat back instructions, and that helps us to prevent errors. Question 33. When performing compressions as part of high-performance CPR, what is the recommended rate for infants? Is it A, 60 to 80 compressions per minute, B, 100 up to 120 compressions per minute, C, 120 up to 140 compressions per minute, or D, as fast as possible?
A, double is your sex sign. B,
revealing the correct response in 3, 2, and you all, they simplified CPR. Regardless of the age of your victim, it's going to be B. We're always compressing 100 up to 120 compressions per minute. And so this rate maximizes blood flow without causing incomplete chest recoil or rescuer fatigue. So whether it's an adult, child, or an infant, your goal compression rate is 100 up to 120 compressions per minute. Question 34. Which action is inappropriate when using an AED? In other words, which action would you not do? Would it be A, removing wet clothing before attaching pads? B, placing pads over a medication patch? C, placing one hand on the upper chest? Placing one pad on the upper chest and one on the side? Or D, using adult pads on a child if pediatric pads are not available.
Which finding confirms fetal viability in the first
So
trimester?
which one of these would not be appropriate?
B, gestational sac.
All right, and if you chose B, you have it. You all were not placing an AED pad on top of a medication patch because doing so could cause arcing, which is like a fire, or it can reduce the effectiveness of the pad. Something else is, let's say that's a nitroglycerin patch, and we apply heat to a nitroglycerin patch. We're about to give this patient a mega dose of nitroglycerin or fentanyl, plus we're going to singe that pad. We're going to burn that pad to their skin. And so what I don't like about this particular image is, yes, with their bare hands, they're showing you the medication patch, but you as a respirator should never remove a medication patch with your bare hands. If you don't have gloves, get something plastic. I don't care what it is. It could be a sandwich bag. It could be a bag out of the trash can, because this is not sterile. You're trying to save their life. If you decide to move a medication patch with your bare hands, remember that medication can go into your skin. It could be fentanyl. This could have been a cancer patient, and now you are going to have the untoward effects. And so you would not remove it with your bare hand. And you also cannot remove it with clothing, because clothing is permeable, meaning that the medication, especially if they're sweaty, it can seep through and it can still get onto your skin. Question 35. I can't believe we're almost done. What is the first step you should take when you see someone collapse? Is it A, start compressions immediately? B, call the patient's family? C, check for responsiveness and breathing? Or D, attach the AED pads? Right, so we're in the mall and we see someone collapse. What's the first thing we do?
So, ladies and gentlemen,
we need to do C. We have to check for a pulse and for breathing. Did they collapse because they fainted? Did they collapse because their blood sugar was low? If either of those two were the case, they still have a pulse and they still be breathing. So yes, they need emergency attention, but they wouldn't need CPR. So that's why I love this image. You have a patient who's on their side, and maybe you called their name and they didn't respond. And because they're on their side, you can't see their chest rise and fall. Well, that's when you go in and you assess your patient. You tap and you shout, you try to stimulate them, and then if that doesn't work and there are no signs of life, you're going to be checking that pulse. Again, maybe they're unresponsive because of medications, maybe they're super sleepy, or maybe their glucose level's low. But we don't know if you don't first check for responsiveness and then check for a pulse and breathing. And so you all, as I promised you, in addition to having our BLS test prep videos, we also have ACLS, we have PALS. You can find that our YouTube channel, which is youtube.com/Florida Training. And it has been so wonderful being with you all today. We have our free study guides. Don't forget at nurseunits.com. And then all of the American Heart Association CPR instructor, BLS, ACLS, PALS, Heart Saver, and we also have CPR and business development courses. Because once you become a CPR instructor, it doesn't teach you about the business. And that's what I'm here to do. So everybody, it's been a pleasure. I will see you in the next video, and then good luck with your test, and thank you for being a lifesaver. Bye everybody.
The amniotic sac, C, the yolk sac, D.
Hello everybody, and welcome. In today's video, I'm going to be showing you how to do an introduction from start to finish. This is Nurse Eunice, the owner of Florida Training Academy, and let's get started.
The yolk sac is the first anatomical
helpful hints. Number 1, always knock on the door before entering the room. Number 2, wash your hands before touching the resident. And number 3, provide privacy by closing the door or curtain. Come in. Hi, Mr. Lucas. Good morning. My name is Eunice. I'm your CNA today, and I'm here to take your pulse. Is that okay? All right, before I begin, let me go wash my hands and provide some privacy.
So the question number 2, at approximately
washing my hands.
Sac diameter MSD should an embryo normally be visible on a transvaginal.
And now that my hands are clean, I'm going to remove this call bell. How are you doing today?
15 millimeters. C,
oh, that's great to hear.
25 millimeters. D, 35 millimeters. Then
it's time for your vital signs to be taken. Is it okay if I start now?
At approximately what?
Count the radial pulse for 1 full minute. If during your test you lose count, ask your nurse if you can start over. Don't forget, practice makes perfect. Practice on your family members, friends, and patients if you currently work in healthcare.
Centimeters without.
So after taking the patient's pulse, make sure you document. And if you need to watch a video on how to take the pulse, I have a video for you. Just look in the description area. So now that the vital signs are finished, I have to end my skill, and you want to end your skill with safety in mind. So anything that you have undone, you need to go back and redo. For example, if you lower the rail, make sure you raise it back up. If you raise the bed up to a working height, make sure you lower it. And in my case, the only safety concern I have right now is giving my patient the call bell and making sure that he doesn't need anything else. So here we go. I have your pulse and it was 78. All of your vital signs are fine. Do you have any questions for me right now? Do you need anything? Well, here's your call bell. Press the button if you do need me, and I'll see you on my next rounds.
What is the most likely diagnosis?
I'm going to open the curtain.
Measures 8 millimeters. But no cardiac.
I'm going to wash my hands again. Don't forget to document your findings. And guess what, everybody? It's that easy. That was an introduction and an exit with Nurse Eunice. See you in the next video.
Unknown location. D. A molar pregnancy.
All right, so before you begin any patient care, you want to sanitize your hands. A napkin is not required when you are initially starting, but I like to use a napkin to turn my water on and to turn my water off. So you want a mixture of hot and cold water. You want to make sure your water is nice and warm. So let's test the water temperature. It feels good. I'm going to wet both of my hands. If you feel that your jacket is going to become an issue, you can take it off before you begin your skill, or you can roll up your sleeves. So now that my hand is wet, I'm going to apply some soap.
Okay.
Keep your hands lower than the elbow, ensuring that your hands do not hit the inside of the sink. If they do hit the inside of the sink, let your instructor, your evaluator, know that you've made a mistake, and she will let you know if you can continue from the mistake or start all over again. So I'm going to clean the palms, the back of an hand, the back of the opposite hand, in between the fingers, in between the thumbs, around the wrist, around the opposite wrist, and I'm going to go up and down every finger. According to current CDC standards, friction should occur for at least 20 seconds. So if you feel that you did not reach 20 seconds, go back and clean more. After my 20 seconds of friction, then I want to proceed to my cuticles and nails. You're literally going to clean around the cuticle and then clean under your nail. You're going to clean around and under every nail. If your nails are extremely short, you still have to clean beneath them. You just don't want to hurt yourself. You would just do a simple scrape. But here I'm literally cleaning beneath my nail as if I'm trying to remove some dirt or debris. If you have long fingernails because you did not cut your fingernails down before your test, you would be scraping them across your palm. But remember, in most facilities, fake nails or acrylic on top of your nails are not allowed. You're now going to rinse the water, rinse the soap off of your hand utilizing the water, remove all soap suds, and once all the soap has been removed, use a napkin to turn the water off. Do not compress this napkin because if you do, you're going to contaminate your clean hand with the dirty napkin. It's the part that just touched the faucet handle. Discard the napkin. Whenever you are drying, hold your hand lower than your elbow and pat dry. If you do the opposite, water can run down your arm. If you need more than one napkin, by all means, get another. Just make sure that your hands are totally dry before you begin providing care. And so everybody, that is it. That is hand washing for the CNA examination. If you liked the video, give it a thumbs up. I hope that you subscribe. And we have a whole video playlist with CNA skills and caregiver skills videos. So we hope to see you in our next video.
Increase NT, which is the knockout translucency.
Hey team, welcome back. It's Nurse Eunice, and in this video, I'm going to show you how to put on and take off your gloves. Yes, remember as a CNA, you cannot perform sterile technique. You're not a patient care tech. You're not a hospital level CNA. So you perform clean technique only, which means that you just use the traditional gloves that will be located within your patient rooms. Just take them out of the box. You have to wash your hands first. We don't want to be contaminating these gloves, because if your hands are dirty, that means that these gloves will be dirty also. So wash your hands before and after removing your gloves. And let's get started. So I have clean hands, and now I'm going to apply my gloves. These are nitrile gloves. I want you to be mindful of any skin allergies you may have. So if you're allergic to latex, just make sure you read. And then also, my future CNAs, make sure that when you're restocking, when you're replacing the gloves, that you replace them for every person that you work with. So just don't replace the medium-sized gloves. If there's a size that's missing, be mindful and replace those too. All right, so let's get started. I'm going to put on my gloves. I have clean hands. I'm going to find the thumb of the glove. So there's the thumb. I'm going to put the first glove on.
So that is the sonographic sign.
Glove is on.
Pregnancy.
And let's repeat that process on the other side. I usually start by putting the glove on my dominant hand first. Is that a requirement? No, it's just something. It's a good technique, but it's not a requirement. So now that I have the gloves on, we call that donning. Now that my gloves are on, I want to show you how you should hold your hands once your gloves are contaminated. Never bring the gloves towards your body. Always keep them out and away. If there is a contaminant, if there are some fluids, it's okay for you to have them fall onto the floor, because you can always go back and clean the floor. What you can't do is have it fall onto your uniform. And so you want to stay as clean as possible, especially when you're working 12-hour shifts and you have so many patients who need you to remain clean to take care of them. So now that I have soiled or contaminated gloves, I'm going to start removing them, not at the very edge. If you try to do so at the very edge, you're going to contaminate your skin. So about an inch below the cuff of the glove, I'm going to pinch and pull off. So now this clean hand cannot touch the outside of this glove. If we do, this hand becomes contaminated. So what we're going to do instead is you can take 1 or 2 fingers. You're going to go under the glove. You're going to pull it off. And then you're going to discard of it into the appropriate waste receptacle. Why do I say that? Because if it has blood on it, it's going to go into the biohazardous waste. But if it's just regular tissue paper or something, it can go into the trash. So let me dispose of this, and I'm going to have you teach me how to perform the skills next. So go ahead and get your gloves, and we'll get started shortly.
The major difference is a pregnancy test.
All right, team, I'm back and I have my clean gloves. Doesn't matter which glove I put on first. Should I start with my dominant hand or my non-dominant? What do you think? If you said dominant, you're right. Let's go ahead and put that glove on.
Which structure develops
Find the thumb,
of the placenta?
glide it on. All right, so glove number 1 is on. Let's go ahead and glove the second hand.
The answer: which structure develops in the fetal side of the placenta? A.
Remember, these are not sterile gloves. These are clean gloves, and you can put them on after you've washed your hands. All right, so now we're going to pretend as if the gloves are contaminated. How do I remove my glove? Do I start from up here first? Is this correct? That's right. That would be incorrect. So hands pointed downward, you're going to pinch, pinch, and pull off. Contain the removed glove. Now, can I touch the outside of this glove? I cannot, but I can take 2 fingers. I can go beneath. I can remove the glove. Don't touch the inside, but you can touch the outside. And you're going to take this and you're going to put it in the appropriate waste receptacle.
Also subscribe and share the link.
Now what do you do with your hands?
Thank you so much.
If you said wash your hands, you're absolutely right. Look, you all, I'm so proud of you. You've just learned how to don or put on and doff or take off your gloves. And I look forward to seeing you in the next video. Bye. Are you getting ready for the CNA examination? If so, don't study alone. Study smarter with Nurse Eunice. That's right. At nurseeunice.com, you can download free study guides and practice tests to boost your confidence. And when you're ready to take it to the next level, grab your CNA exam prep workbook, available at booksbyeunice.com or nurseeunice.com. All right, so let's talk about how to take a pulse. And so there are different points throughout the body where you can actually feel someone's pulse or pulsation. And so every time the heart beats, contracts, blood circulates, and at different points throughout the body, you're going to be able to feel a pulse. The normal pulse or heart rate for an adult is 60 up to 100 beats per minute. If the heart rate is greater than 100 beats per minute, that is called tachycardia. If it is less than 60 beats per minute, that is bradycardia. You would notify your nurse of any abnormals or if your patient has any additional concerns. And for CNAs, the pulse that we feel will be the radial pulse. So everyone say it with me, radial. If you come up to your patient and your patient's talking to you and they're responding, do not go for their carotid pulse. Carotid pulses are for emergencies only. And so to locate the radial pulse, Mrs. Loretta, is it okay if I hold your hand?
Yes, ma'am.
And I'm going to take this call bell out the way because we won't be using it right now. The radial pulse is located in the wrist area at the base of the thumb. And whenever you're taking a pulse, I want you to remember that you shouldn't be wearing gloves unless your patient's on isolation. So for your CNA examination, of course, you wash your hands, you do your introduction, but no gloves because gloves decrease the sensation and you'll be less likely to get an accurate reading. Also, you cannot take a pulse with your thumb because if you do, you'll actually be feeling your own heart rate. You'll be feeling your own pulsations. So the way that I do it is 3 fingers. And so research has indicated you can take a pulse with 2 or 3 fingers. Both Loretta and I have worked on cardiovascular units with patients who may have irregular heartbeats, etc. So for me, I've always used 3 fingers, but you use what's best for you. 2 or 3 fingers are allowed. Think about circulation. If I raise this wrist up, this arm up, the blood flow is going to decrease. So whenever you're taking someone's pulse, keep the wrist down. Put 2 or 3 fingers on the pulse. We have a clock over here that I'll be using. At your test sites, if allowed, you can wear a watch, but usually you and your nurse will be on one side, you'll be on the other side. And so your nurse evaluator will be counting the pulse at the same time you would. And so you and your nurse, can I please get you to stay on the other side, please? Like right here on this other side? Yes. And so would you please gather her wrist? You're going to get a wrist. All right, and so we're going to be looking at the clock that's over there. All right, and so you're going to put 2 fingers here. And do you feel those pulsations?
Yes.
All right, and so I'm going to tell you when to start, okay?
Okay.
All right, so let's go ahead and start now on the 12th. We can start. All right, great job. And so at your test site, you would never know your nurse's number. The count that I received was 78. What number did you count?
78 as well.
Very good, very good. So at your test site, you can be 4 away from your nurse's reading, and you have to count the pulse for 1 full minute. So I know what they do in the real world. You'll count for 15 seconds and multiply that number by 4, or maybe 30 seconds and multiply by 2. But when you're testing to become a CNA, you want to do it for the full minute. And if you lose count, or if you feel that you have maybe the pulse isn't as strong in one wrist as it would be in the other, you can tell your nurse that, hey, I need to start over, or may I start over? You can also ask your nurse if you can switch extremities. And so don't forget to document your findings. For your state of Florida CNA exam, usually the pulse is by itself. In the real world, we can do pulse and respirations, but for the test, you'd have to do a whole introduction, take the pulse, document the pulse in your skill by giving the patient a call bell, making sure their bed is back low, etc. Don't forget to wash your hands if I didn't say that. And then if you had to do respirations, you'd have to knock on the door and start that process all over again. So I just did the pulse skill. I would make sure I tidied up everything that I documented. I washed my hands and I opened that curtain at the end. I would give the patient back their call bell, ask if they have any questions, and then I would be done with this skill. I would then have to knock on the door, come back again in order to do respiration. So that's what we do for the Florida CNA examination. If it's different in your state, please let us know. Again, this is Eunice and this is Loretta. And we are here at Florida Training Academy, so we look forward to seeing you in the next video, which will be about respirations. All right. Are you getting ready for the CNA examination? If so, don't study alone. Study smarter with Nurse Eunice. That's right. At nurseeunice.com, you can download free study guides and practice tests to boost your confidence. And when you're ready to take it to the next level, grab your CNA exam prep workbook, available at booksbyeunice.com or nurseeunice.com. Thousands of future CNAs have already used Nurse Eunice's resources to pass on the first try. Now it's your turn. Visit nurseeunice.com today. Train, learn, and succeed. So let's talk about respirations. And so whenever you're counting a patient's respirations, you're actually letting your nurse know how well this patient's breathing. And so a normal respiration rate for an adult is 12 to 20 breaths per minute. And so a breath would be one inhalation. We're actually breathing in oxygen, and then one exhalation. So in and out. Breathe in oxygen, let out CO2. And that would be the full process. So as far as your patient's concerned, whenever a patient takes a deep breath in and then they release it, that process would be one breath. In, out, one. So if your patient's respiration rate is lower than 12, maybe you need to stimulate them, try to wake them up a little bit, but don't be afraid to notify your nurse. Get your nurse in the room, because whenever we're giving pain medications or sedatives will relax your patients, but it also causes them not to breathe as effectively. And then if a patient's anxious, maybe they're having an anxiety attack, or if they're having a lot of pain, their respirations may increase. So remember, 12 to 20 is the normal range. Anything outside of that, let your nurse be made aware. And so now we're going to focus on Mrs. Loretta's respiration rate. Whenever you take your test, don't forget you do the whole introduction first, and then after your introduction, which includes hand washing, you can tell your patient to relax. If you're having difficulty with seeing your patient's chest rise and fall and they are laying flat, you can sit them up. Opposite, if they're sitting up and you can't see the chest rise and fall or the stomach rise and fall, you can lay them flat. But play with the position as you need to in order to make sure that you get an accurate respiration rate. And then one more thing that I want to discuss is that you cannot let your patient know that you are going to be counting their respiration. So what we say instead is a blanket term. My name is Eunice. I'm your CNA today, and I'm here to take your vital signs. Is that okay?
Yes, ma'am.
So you want to keep the element of surprise, because if you tell them that you're here to count their respirations, they stop breathing on you. They're like looking at you, looking at them. So I'm going to go ahead and begin Miss Loretta's vital signs, aka respiration, shortly. All right, so Miss Loretta, is it okay if I hold your wrist?
Yes.
Right. And I'm holding her wrist to keep the element of surprise. I'm not holding her wrist because I'm actually taking the pulse. Instead, for the next 60 seconds, I'm going to look at her chest rise and fall. And I know what you do in the real world. You lie about the respiration. Stop lying. Everyone's respiration rate isn't 14. Stop documenting that. We can check the chart history and see that you're not telling the truth. So really count your patient's respirations, because again, if it's too low or it's too high, you could be the person that helps protect your patient from maybe receiving too much medications. And so now we're going to focus on the chest rise. All right, pretend that I'm still holding the wrist. For video purposes, I'm going to be counting with you. All right, and we're going to start now. 1, 2, 3, 4, 15, and 16. All right, and so now that you've actually taken the respirations, of course, you can give your patient back the call bell. Don't forget to document your findings, wash your hands, and open up the curtain if you had closed it.
Ms. Jenkins, I'm here to do your pulse and respirations. I've already washed my hands and I've closed the door for privacy.
Okay.
And I'm going to begin now. Count the pulse for 1 full minute. Then watch the resident's chest rise and fall for another full minute. 1 exhalation and 1 inhalation equals 1 breath. Okay, done. I've finished your pulse and respirations. I'm going to go document now. You have your call bell. Anything else I can do for you?
No, thank you.
All right, thank you very much. Wash your hands and document. So this is an illustration of the gauge on a sphygmomanometer or a blood pressure cuff. Because it's going to be harder to read on the actual cuff itself, we're going to use this drawing or this illustration over here to show you how to read the gauges so that you get your numbers accurate when you're taking someone's blood pressure. And the blood pressure is a measurement of the pressure of the blood flowing against the walls of the arteries. The arterial blood pressure is constantly changing during the course of the cardiac cycle. The highest pressure in the cycle is called the systolic blood pressure. That's the top number. The lowest is the diastolic blood pressure. That's the bottom number. Both readings are necessary to enable you to evaluate the status of your patient's blood pressure. And so in order for you to accurately obtain a blood pressure reading, you have to be able to read this gauge. If your gauge is calibrated, it's always going to start off here where it says mmHg. That's millimeters of mercury. That's how much pressure. And so we increase the pressure by actually squeezing on the bulb, and I'll show you that in a few moments. And so our machine is calibrated, is directly in the center at the bottom, which represents 0. Here we have a dark line, a long dark line, followed by 4 short lines, another long dark line, followed by 4 short lines, and then another dark line. This is how it reads. Everything's in increments of 2. You cannot get an odd number when you're taking a manual blood pressure. If you're using an automated blood pressure cuff, then sometimes an odd number will be seen. But if you're using an earpiece, a stethoscope, and a manual blood pressure cuff or a sphygmomanometer, you should not obtain odd readings. So here we go. 20. Small line above will be 22. 2 small lines above 20, 24. 26, 28. Long line with no number would be 30. Let's keep it going. 32, 34, 36, 38, 40. And so now I want you to pretend as if we are inflating the bulb. We're pumping, 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 pumping. Our patient told us that their systolic blood pressure is normally 120, so we're just going to take it 30 above to 150. Now, that's the cheat way. When you're in nursing school, they may teach you a little bit differently, but I'm going to show you the quickest way possible so that you'll learn fast, and then you can add those extra techniques when you're in nursing school. So you would actually inflate the pump to 150, and then you start. Right, so we're going to pump the cuff up to 150, and then we're going to gradually release the air valve. We're going to turn it counterclockwise. We're going to turn it back towards us. And the needle should drop about 2 millimeters of mercury per second. And so where you hear the first thump is going to be called the systolic pressure. And so here it is. Let's say we heard our first thump here. You're going to continue to release the air slowly. And wherever you hear the last thump and it gets really light, that would be our diastolic pressure. You remember where you actually heard your sounds. One line below this dark line would represent 128. And then one small line above this line, if this was 60, this would have to be 70. That would make it 72. So if you were writing this blood pressure down, you chart it as the blood pressure being 128 over 72. Now let's put it all together. We know how to read the gauge. Whenever we're practicing I always ask that you practice without an arm in the cuff until you know what you're doing. And so I know your family members want to help you, but actually just have the cuff wrapped on itself. We talked about this bulb. We have the air valve here. We're going to tighten the air valve by turning it away from us, but don't tighten it so tightly to where you can't open it with 2 fingers. So you're going to close it. You'll know when it's closed because you won't be able to turn it any further. But again, don't make it so tight until you can't open it up with your 2 fingers. I like to keep 2 fingers on the air valve at all times, but here we go. We have it closed. And now we're going to start inflating. And remember, when you're just starting off, my recommendation is that you don't use anyone's arm because you need to learn how to control this gauge. All right, so the needle's dropping a little bit. What I'm going to do is I just closed it tightly to stop it just for classroom purposes so I can show you what to do. I'm going to put 2 fingers on the air valve and I'm going to slowly move it towards me. I'm turning it very slowly and I'm letting the air release from the blood pressure cuff about 2 millimeters of mercury per second. And remember, if you are using your stethoscope, where you'd hear your first thump or your quarter cuff sound would be the systolic blood pressure. Where you hear the last quarter cuff sound would be the diastolic blood pressure. And once you hear no more sounds, you release all of the air from your blood pressure cuff. Let's practice once more. What do I need to do to my air valve? I'm going to turn it away. I'm going to close it, but not make it so tight until I can't open it with my 2 fingers. Once it's closed, you can do the 2-step method where you feel the radial pulse until it no longer, and inflate the cuff until you no longer feel any pulsations. And you can go 30 above that number, or you can just do the easy way I'm going to show you. Just inflate the cuff to about 150 if it's someone who does not have a history of hypertension. If they have a history of hypertension, you may have to go to 180 or 200. So here we go. And in nursing school, they'll teach you a different way. Right now, I'm just teaching you how to control your needle, release your air. And if you can control this needle, you can slow it down, you can speed it up. And remember, when you don't hear anything else, when you hear your last thump, you release all of the air out of the blood pressure cuff. And then you remove it, take it off of your patient's arm. So this was our practice without a patient. In the next video, I'm going to show you how to actually take a blood pressure and use a stethoscope.
Hello, everybody, and welcome. My name is Nurse Eunice, and in today's video, I'm going to be showing you how to perform a manual blood pressure. And I have my wonderful assistant, Anijah. She's going to be in a couple of our videos. So one of the first things you want to do is, of course, hand hygiene. You want to perform that first. So over here, I do have hand sanitizer on our station. We also have our blood pressure cuff, which is also called a sphygmomanometer. And then we have our stethoscope. If you're going to be using your equipment for multiple patients, you want to also ensure that you have alcohol swabs so that you can be cleaning the earpieces and the diaphragm of your stethoscope before you use it on a different patient. And if you're using your blood pressure cuff on multiple patients, you want to make sure you also have wipes so that you can be cleaning your equipment and sanitizing it. We don't want you putting dirty equipment back in your care. And one thing I always like to do is to ask, is it okay if I take the blood pressure on a particular arm? So Anijah, can I use your left arm?
Yes.
Right, awesome. All right, so we're going to go ahead and we're going to place the blood pressure cuff or the sphygmomanometer. I do have another video in which I'll be showing you how to read the device. So if you've never read a blood pressure cuff before or a sphygmomanometer, just check in the description area for a separate video link. All right, so prior to placing the cuff, we actually have Anijah's arm on a flat surface. And so she's sitting upright. We have her arm at the level of the heart. We're going to go ahead and bring the sleeve up. When you're applying your cuff, it has artery indicators. It has arrows on the actual cuff. And what the arrows indicate, I'm going to have your palm up for me, is this is left arm and it's pointing to the brachial artery. And so whenever you all are in nursing school and you're in the programs and you don't place your stethoscope properly, I know because number one, there's an artery indicator, which lets me know that the brachial artery is going to be on the inner aspect of the left arm. And that's also the location or the place where you be putting your stethoscope. So knowing your positions of your brachial artery, and remember, if you can see it, it's not an artery. If you can see it, it's a vein. Whenever you're doing your cuff placement, you don't want the cuff too high. You don't want it too low. This is the antecubital area. You want to make sure it's at least 2 finger breadths above the antecubital area so that you have enough room for your stethoscope. And then you're going to apply the cuff. Now, as far as your stethoscope is concerned, whenever you're placing the earpieces in your ear, you want to test your equipment. You're going to tap on the diaphragm of the stethoscope. This is the diaphragm, which is used for adults, and this is the bale that's usually used for pediatric patients. You want to tap on the diaphragm, and if it doesn't make you jump, chances are your stethoscope's not on. Some of your stethoscopes will turn. You want to turn it until it's in the on position. And now we're going to place the diaphragm of the stethoscope on top of the brachial artery. And I'm just going to reposition this a little bit so I can see it. Make sure your tubing is not hitting the stethoscope. So I'm going to move this over. So now that we're ready to place our stethoscope, we're going to place it on top of the brachial artery, like so. When you're holding your stethoscope, try to keep your hands off of the tubing. Otherwise, you're going to have additional background sounds. So we have the brachial artery here. All right. And so this is where we're going to place the stethoscope. Whenever you are going to be inflating your stethoscope, you have to turn your valve. And remember that righty, tighty, lefty, loosey. So if you want to tighten this up, you turn it towards the patient. If you want to release the air, you turn it away from the patient. All right, we're going to inflate it to about 160. So here we go. You'll see the needle moving. Okay, so we're at 160. I'm going to turn it slowly towards me. And you'll be making note of the first heart tone or cortical sound that you hear and also the last. The first heart tone would be known as the systolic and the last would be the diastolic. And I'm just going to repeat that again so that you understand it. We've located our brachial artery. We're going to place the stethoscope on top of the brachial artery. We're going to turn this away, making it tight. I'm going to inflate the cuff to 160. You go up to as high as 200, depending on the history of your patient. If they have a history of hypertension, you go a little bit higher. You're going to slowly deflate. And note where you hear your first cortical sound and your last cortical sound. I want you to keep practicing taking the manual blood pressure. And remember that practice makes perfect. If your patient has a history of hypertension, you would start your blood pressure cuff. You would go ahead and inflate it so that the needle is about 40 above their last known reading or their highest reading. For example, if the person's last systolic blood pressure is 160, it would be okay for you to inflate the cuff to 200. If you lose count, if you're not sure, let all the air out of the sphygmomanometer or the blood pressure cuff and start the process over again. We're usually only allowed 2 opportunities to take a blood pressure on each extremity. So if you attempt the blood pressure twice on the left arm and you're unsure of your reading, you would then have to go to the alternate arm. If you keep squeezing, if you keep applying pressure, there's going to be less circulation. It's also going to be increased pain, both of which would negatively impact the blood pressure reading. And so if you want to purchase your own blood pressure kit, I got this one off of Amazon for less than $25. If you're not a fan of the loud, bright colors, of course, they have have blue, they have black, they have red, they have purple. So I'm going to have a link in the description area below. Are you getting ready for the CNA examination? If so, don't study alone. Study smarter with Nurse Eunice. That's right. At nurseeunice.com, you can download free study guides and practice tests to boost your confidence. And when you're ready to take it to the next level, grab your CNA exam prep workbook, available at booksbyeunice.com or nurseeunice.com. Thousands of future CNAs have already used Nurse Eunice's resources to pass on the first try. Now it's your turn. Visit nurseeunice.com today. Train, learn, and succeed. Hey everybody, welcome back. This is Nurse Eunice, and in this video, we're going to be showing you how to weigh a patient. And so whenever you're thinking about weighing a patient, although this may not be on your state's examination, you still have to know how to perform the skill, because some of your patients require daily weights. And that'll usually be a patient who is maybe malnourished, they're not eating enough. It could be somebody who has congestive heart failure, or they're at risk of retaining fluids. It could be somebody who's on dialysis. Well, because their kidneys aren't working, they're not excreting the excess fluids, they could retain the fluids, and that too could back up into the heart and the lungs. So whenever your nurse asks you to perform a daily weight, at least now you will know why you're doing it. Another thing I want to discuss before we start the skill is to make sure that you do your weights first thing in the morning before your patient has eaten, and also make sure they use the bathroom. If you have a balance beam scale, you'll have to go ahead and zero it. We have an electronic scale, and that's what we're going to be using today during our demonstration. And we're going to get started now. With every skill, you're going to knock on the door before entering the room, and then you're going to greet the resident. Hello, Mr. Mitchell. My name is Eunice. I'm your CNA today, and I'm here to weigh you. Is that okay?
Yes, ma'am.
All right, before I begin, let me go wash my hands. I'll be right back. Don't forget to wash your hands. For the CNA exam, you'll be washing your hands before and after the skill, and also provide privacy. So what have I done so far? I've knocked, I've introduced myself, I've greeted the resident, I've explained the procedure, I've gotten their permission, and then I've washed my hands, and I've also provided privacy by closing the curtain. And now let's get our patient up. Let's get them sitting upright. All right. And so, are you able to sit up? Can I assist you?
Yes.
Great. All right. Now let's scrape your legs over, okay? Okay. All right. And before we stand you up, let's get you to scoot just a little bit. I want to make sure your feet are flat on the floor. And before we get you up, how do you feel?
Fine.
All right. No dizziness?
No, ma'am.
All right. And even though I didn't say it before, Mr. Mitchell has non-skid socks on. And so if your resident or your patient did not have the non-skid socks, you would then put their shoes on. But this is going to be best for the weighing skill because it doesn't add as much weight. All right, so on the count of three, we're going to stand, okay? 1, 2, and 3. You're still feeling okay?
Yes, ma'am.
And so we have an electronic scale here. I'm going to help you on the scale, and then we're just going to put my arms around you once you're on the scale, just in case you lose your balance, okay? All right, let's go ahead and get you to step on. Thank you so much, Mr. Mitchell. Let's get you to step off, please. All right, so if I can get you, you can either step back or you can turn towards the bed. Okay, great job. Do you need help getting your legs back in the bed?
No, ma'am.
Okay, all right. And here's your call bill, Mr. Mitchell. Is there anything else I can help you with?
No, thank you.
All right, I'll see you in a few moments, okay?
Thank you.
So now that we've finished the scale, I want you to pick up your scale. If your facility requires that you clean it off, by all means do so. But don't forget to document. That's right. But I want you all to document for me. In the United States, we document in pounds. However, if your facility requires that you document in kilograms, you'll do so by dividing the number of pounds by 2.2. So whatever the number of pounds were divided by 2.2, and that would give you the weight in kilograms. But you must document after you perform the weight. Don't forget to go wash your hands, open up that curtain, and then just to look back. Make sure that the bed is in the lowest position, that your patient or resident has their call bell. One last thing I want to add. In the state of Florida, if you're taking a CNA examination, the side rails are optional. So if the side rails are there, you're welcome to raise the rails. However, if they were lowered when you came in, you can also perform the skill and keep them lowered. The goal is for you to be able to provide care and provide care safely. So you're not passed nor failed on the absence or presence of the side rails. You are judged on how you provide the care and whether you can do so safely. So I hope you learned a lot from this video. Remember, we have to do those weights. It helps to monitor the health of our patients. And I'll see you in the next video. Hello, I'm Nurse and the owner of Florida Training Academy. In today's video, I'm going to be showing you how to brush the teeth of someone who is in the bed. I have all of my supplies here, which will include a towel that we'll use as a clothing protector. I have the toothpaste and toothbrush. Of course, I have clean hands with gloves on them. I have the emesis basin, a cup of water, and I'm going to go ahead and start the skill. You want to be mindful of safety. And so in order to prevent our patient from aspirating, what position do we need to put our patient in before we put water in his or her mouth? And if you said upright 90 degrees, that's perfectly correct. The Fowler's position can go from 60 degrees all the way up to 90. I just feel more comfortable raising my patient up as far as they can tolerate. So I'm going to go ahead and raise our patient. Are you doing okay today? If you feel like you need to reposition, you can go ahead and do so. I'm going to put a towel over your chest. Would you like a sip of water before we start?
No, thank you.
I'm going to wet the bristles of the brush. Apply a small amount of toothpaste. And this one is mint. Are you okay with mint?
Mm-hmm.
And now we're going to perform the skill. Okay. And with my clean gloves, I'm going to go ahead and open up your mouth. All right. We're going to start off with the front teeth. Going to go inside. I'm going to repeat that process up top. And now that I've brushed all, and if you go ahead and cinch or clench your teeth together for me. All right, so now that I've brushed all the surfaces, if you'll stick out your tongue, I'm going to brush your tongue. I'm going to now give you some water so that you can gargle. Good, and we'll let you rinse one more time, and I'll make sure I clean your beard. Very good. Clean your mouth and your beard. So now that I'm done with the brushing of the teeth, I'm going to throw away my disposable supplies. After emptying the contents of my emesis basin into the toilet, I would have to use a napkin in order to turn the water on because my gloved hands cannot contaminate the sink or the faucet handles. So I would rinse, pour out my rinse water, and then I would dry the inside of the emesis basin. Of course, I would store whatever supplies I have left. Don't forget to take off your gloves, wash your hands, reposition your patient, put that side rail back up, and make sure that he has his call bell in his hand before you leave. And then also remove the protective covering. All right, everybody, this is Eunice Mathis for Florida Training Academy. We wish you the best of luck with your future CNA examination, and we hope that this skill will help you to pass your test and also provide better care for your residents. Hello, everybody. Welcome back. This is Nurse Eunice with Florida Training Academy. And in this video, we're going to be showing you how to clean dentures. We know that dentures are extremely expensive. And so you want to make sure your dentures are in a case. For the state of Florida exam, don't forget that denture care is a two-part skill. After cleaning the dentures, using the denture brush and the denture paste, which don't have toothpaste, you have to go back and provide mouth care. And when you're providing mouth care, you're pretending like your partner does not have any teeth. Remember, it's just a test. Even if someone did have real dentures, they're not going to take them out just so you can pass your test. So since you're pretending that your patient doesn't have any teeth, instead of using a toothbrush to cleanse their mouth, you're going to use that toothset or swab. And I'll make sure that I have an image so that you can actually see what that looks like if you've never seen one before. But let's focus on first things first. Let's focus on denture care. All right, so I'm going to go ahead and open up the cap and place my dentures on the countertop. I'm going to put a washcloth in the base of the sink. We know that when dentures come out of someone's mouth, they're really slippery. And so we don't want them to hit the porcelain, the inside of the sink, and be damaged. I'm also going to start running some cold water. We only want to use cool or cold running water on our dentures. We don't want the water too hot because real dentures could be affected or reshaped by the hot temperatures. I'm going to go ahead and wet the bristles of my denture brush. At the test site, they may have you using toothpaste, but in the real world, we use denture paste on dentures because toothpaste would cause abrasions that would allow germs to grow on the denture and cause the dentures to have an odor. So test site, you use what they have. Real world, use denture paste on dentures. I'm going to rinse off the dentures. Remember, for this scenario, the person just removed the dentures from their mouth and they're preparing for bed. I'm going to brush all surfaces of the dentures. This angular portion, let's say there was some adhesive or something in the denture, I can remove that, or some food particles. I can use the angled portion for that. Make sure you hold the denture securely, and when you're done, there should be paste all over your denture. You can now rinse. Make sure you also rinse your denture. When you store the dentures in a cup, especially if you have the upper and the lowers, think about the orientation, how they go in the mouth, and that's how you want to put them in the cup too. So since these are the upper dentures, we're going to put them in the cup with the teeth down and the gums up. And now, so the dentures don't dry out, I'm going to put water into the cup so that the dentures are actually beneath the water. That's going to make sure the dentures are comfortable for your patient. At the test site, your nurse might tell you to pour the water out. Do whatever he or she tells you to do. I can now turn off the water. Remove my washcloth. I'm going to go ahead and take this washcloth to the laundry basket. I can now take my denture supplies back into the clinical room, open up the cabinet, and store them. And don't forget, denture care is a two-part skill. After performing denture care, you have to perform the resident's mouth care. All right, everybody, again, this is Nurse Eunice with Florida Training Academy. I hope you liked our videos. Go ahead and like and subscribe. Share our videos with a friend. And if you know anybody who's interested in being a CNA or a nurse, this is a great place to start. Plus, you get to do so for free. All right, everybody, have a blessed day. Bye. In this video, I'm going to be showing you how to feed a resident. And don't forget that, monitoring your patient's fluid and food intake is so important. It helps to prevent malnourishment. It also helps to prevent dehydration. And so at the end of the skill, don't forget to document. And of course, as with every skill, I've already washed my hands. I've provided privacy. I've provided privacy. I've put on gloves. I've explained the procedure to our patient. And now I'm going to get our patient in the safest position for someone who's going to be fed. I'm going to get him upright to a high Fowler's position. Is it okay if I change your position now? And Patrick is a wonderful patient actor. If anyone in Florida is looking to hire this wonderful actor, I will make sure that I have the contact information for you. And of course, right now, yes, he's giving Jesus vibes. I know it. All right, so now that I have my supplies on my table, I'm going to go ahead and put a towel on his chest in order to protect his clothing. For the Florida Certified Nursing Assistant examination, you always want to offer the person an opportunity to wash their hands before feeding. And the reason why you want to make sure the resident's hands are clean is because in real life, your patient may either reach up and touch you, or they're going to try to assist and touch their food and they're going to contaminate it. So Patrick, half of the washcloth is wet, the other half is dry. Would you go ahead and cleanse your hands for me? And then flip and you can dry your hands with the other half. Okay. You would now take this and put it in a laundry basket. During the Florida CNA examination, you will have 2 different food choices. Patrick, is it okay if we feed you applesauce today? And a song or a mnemonic that I made here at Florida Training Academy is hands, water, 3 bites, water, wipe. Go ahead and repeat that with me. Hands, water, 3 bites, water, and then wipe. If you can do those 5 steps, you're going to pass the CNA examination. So I've already washed Patrick's hands. Now I'm going to give him water in order to wet his mouth. The way I like to think about it is if you are giving a patient something to eat. Let's say it's a biscuit and they're just waking up. They have a biscuit with their breakfast tray and they're on oxygen, or if they're on a medication that can dry the mouth. If you just give them a biscuit without giving them water first, it's going to make it really hard for them to swallow. So we're going to help Patrick by giving him water before we give him food. Everything went down okay? Now we're going to feed our resident using a spoon. However, we're not going to overfill the spoon. We're only going to put half of the applesauce. We're only going to put half a spoonful of applesauce on the spoon, and we have strawberry applesauce, which is your favorite. And can you open up for me? Very good. We're going to repeat that 2 more times. Awesome. And then this is the last bite that we have to provide for the state of Florida CNA examination. Good. All right, so let's go back to our song. Hands, water, how many bites? 3 bites, making sure you check the mouth after each bite. And we want to make sure that the food really gets down. So we're going to provide water next. Here's some more water. Okay, everything went down okay? For the state of Florida exam, you cannot leave anything wet. So we just gave our resident water. We want to make sure we dry his mouth and his beard. We're almost done. Hands, water, 3 bites, water, wipe. I want you to think about a person who's depressed, especially depression in the elderly. If an elderly person does not want to live, how would they help to ensure that they are not with us much longer? I don't want to say how would they commit suicide, but the way that a person would die in your nursing home is by refusing to eat. And so after you feed someone their 3 bites of food, you want to ask them if they want more. Of course, in the real world, you feed them as much of the food as they want. My rule of thumb is if my patients don't eat 50% or more of 2 meals, I want you to go ahead and notify that nurse, because we can contact the doctor, we can get supplements ordered, we can help that person get the nourishment that they need, even if they may not want to eat it. We can use other mechanical devices to ensure that they're getting the nutrients. So hands, water, 3 bites, water, wipe. Would you like more to eat? Would you try another bite for me? Just one more bite? Okay, very good. Here we go. Did it go down okay? And here's some more water to wash it down. All right. I'm so proud of you, Mr. Patrick. Wipe your mouth. I'm going to remove this, okay? You're also going to place your clothing protector in the laundry basket. And Mr. Patrick, I know you normally like to lay back, but I have to give your food time to digest. So for about 30 minutes, I will lower you a little, but I can't lower you flat until your food has digested. Are you okay with that? Take off your gloves. Dispose of your gloves in a trash can. Make sure that you lower the bed. If you raise it to a working height, raise the side rail back up. Leave your resident with a call bell. Don't forget to document. For the state of Florida examination, food intake is documented in percentages in increments of 25. And so he didn't eat none, he didn't eat 0, and he definitely didn't eat 50%. We document 25%. All right, everybody, this again is Nurse Eunice with Florida Training Academy. We hope that you're able to feed someone safely. Don't forget that after you feed them, don't lay them all the way down immediately. Give that food time to digest. So about 30 to 45 minutes later, you can come back and lay your patient down. You know our closing techniques. Open up the curtain, wash your hands, document, check on your patient, make sure they have the call bell. Bye, everybody.
Are you getting ready for the CNA examination? If so, don't study alone. Study smarter with Nurse Eunice. That's right. At nurseeunice.com, you can download free study guides and practice tests to boost your confidence. And when you're ready to take it to the next level, grab your CNA exam prep workbook, available at booksbyeunice.com or nurseeunice.com. Thousands of future CNAs have already used Nurse Eunice's resources to pass on the first try. Now it's your turn. Visit nurseeunice.com today. Train, learn, and succeed.
Come in. Hi, good morning. Good morning. My name is Eunice. I'm your CNA today, and I'm here to do your hand and nail care. Is that okay?
Yes, ma'am.
All right, before I begin, let me go wash my hands.
Okay.
Hands are clean. Closing the curtain. And may I take this? Thank you so much. Can you raise your feet for me? Bring them over the rail. Perfect. And you can lower them. All right, may I hold your hand? I just want you to test the water temperature. Is that okay?
Yes, ma'am.
Very good. So let's test the water temperature one more time. Still okay?
Yes,
I'm just going to move this over just a little bit.
Okay.
And for those who are viewing in preparation for the CNA exam, you only have to clean one hand. So we have clean water that does not have any soap inside the basin. I'm going to go ahead and keep my washcloth folded. I'm going to fold it once more. I'm going to wring it out over your hand. How does that feel?
Good.
And we're only going to apply 1 drop of soap. Still feeling okay?
Yes, ma'am.
Rotate your hand. Put this to the side. I'm going to rinse your hand now. All right, so this is an orange wood stick I have to clean beneath your nails. Okay. So I'm going to clean and wipe. Clean and wipe. Am I hurting you?
No, ma'am.
Perfect. I'm going to bring your hand down and support it. Because your nails are already manicured, I just need to make sure they're not jagged. I'm just going to foul just a little bit.
Okay.
Still doing okay?
Yes.
I'm going to apply lotion. And I need to remove the excess lotion, okay? You still feel okay?
Yes, ma'am.
Can you raise your feet for me? Okay, so now that I've taken all the items away, here's your call bill. Is there anything else that I can get for you right now?
No, ma'am.
Okay, I'll come back and check on you during my next round, okay?
Okay.
All right, I'm opening up the curtain. I'm going to go wash my hands and document if I have to do so. Everybody, this is Nurse Eunice with Florida Training Academy. This was our demonstration on how to provide hand care for the state of Florida exam. You can watch our videos on YouTube and also on my personal channel, which is nurseeunice.com. We'll see you in the next video. Bye-bye. All right, so this is our foot care skill, and we have the wonderful Tanisha here who's helping us for the state of Florida examination. You only have to perform foot care on one foot. We have a towel on the floor because the barefoot cannot touch the floor. We also have an additional towel that we'll use for drying. We have washcloths. We have a basin of water that is comfortable. We've already had Tanisha check the water temperature. We also have soap and lotion. Notice that we do not have any toe utensils. We're not trying to clip toenails, and we're also not going to foul toenails. That is not a CNA duty in the state of Florida. All right, so before I begin foot care, I'm going to go ahead and put on some gloves. And we have you check the water temperature with your hands. However, now I want you to check it with your foot also. Can I get you to check the water temperature with your foot? Is it still okay? Yes, we'll move this over just a little bit. All right, we're going to begin the washing process. We're going to wet it, bring it out. Apply 1 drop of soap. I'm going to bring your foot out just a little. Thank you so much. And we're going to begin the washing process. I'm going to wash the top. I'm going to go in between each toe. I'm also going to clean the bottom of your foot. How does that feel? It feels good. Okay. Let's go ahead and rinse. And this is a really easy skill. Pretty much I wash the foot, I rinse the foot, and I dry the foot. So I'm going to support your foot. I'm going to bring it out. Great job. I'm going to move this over. I'm going to put this on the floor. And I'm going to pat your foot dry. I also have to make sure that I dry between the toes. And you're still doing okay?
Yes, ma'am.
Now, as far as lotion is concerned, I'm going to warm it up first. And then I'm going to apply that to your foot also. Let's read this up. Let's give a little bit extra to that heel, okay? Great job. And for the Florida exam, even though we normally let this absorb, I have to remove the moisture right away. And just as a reminder, we do not put lotion between the toes. Let me take this away. Great job. So now I have to assist you and put your shoe and your sock back on. So let me support your foot. Thank you so much. And there's your shoe. And now I'll take all this away. Correction. The towel touched my leg. All right, so once you've completed foot care, you want to clean all your items. Of course, you're going to rinse and dry your basin, store everything where you received it from, put up your dirty linens, your dirty washcloths and towels, and then you have to take off your gloves. The proper way to take off your glove is that you'll pinch from the palm, pull down, contain the removed glove into the dirty glove, and then you go under, remove the second glove. Take this to the trash can, wash your hands, and you know how we end every skill. We make sure our hands are clean, that the curtain's open, that our resident has the call bell, and that if we have to document, we do so for the skill. This is Nurse Eunice with Florida Training Academy and nurseeunice.com. We'll see you in the next video. All right, so this is Eunice with Florida Training Academy and nurseeunice.com. And in this video, we're going to be performing the transfer from the bed to the wheelchair skill. As we begin every skill, we always want to knock and introduce ourselves. Don't forget to wash those hands, provide privacy, and remove the call bell. So let's prepare our wheelchair. Before we put a patient inside of a wheelchair, we first want to lock the brakes. The pedals or the footrest should be up. And then there's usually a lever on the inside of your wheelchair that once you engage it or pull it, it should allow the leg of the wheelchair to go back. So when you're putting a patient in the wheelchair, there shouldn't be anything for your patient to step over. Let's do this again for classroom purposes. All right, so I just pulled my wheelchair to the patient's bedside. What's the first thing I do to ensure safety? If you said lock the brakes, you're absolutely correct. Let's lock the brakes. You don't want your patient stepping over anything because they can fall. So we're going to raise the pedals and then move the legs out of the way. And this is how you prepare your wheelchair for a patient to be transferred from the bed to the wheelchair. Knock. Come in. Hi, good morning. My name is Eunice. I'm your CNA today, and I'm here to put you in a wheelchair. Is that okay?
Yes.
All right, before I begin, let me go wash my hands.
Okay.
All right. And so don't forget to wash your hands. Hands are clean. We're going to provide privacy by closing the curtain. And I'm just going to remove this because we don't need it right now. How are you feeling today?
Feeling good.
I'm going to prepare my wheelchair first. So I'm going to lock the brakes as we showed you in another video. I'm going to bring the pedals up, bring the leg of the wheelchair back, and repeat the process on the opposite side. Okay, I'm going to gather your legs and bring you over. Okay, can you scoot over a little bit for me? It'll be a little bit easier. All right, perfect. And 1, 2, 3. Let's go ahead and get you over to the side. All right, we have to make sure that your feet are on the floor, so I'm going to try to lower the bed a little. And this is as low as the bed goes. So let me get you some shoes on. And then I'm going to make sure that your feet are touching the floor. Can you touch the floor for me? Great job. We're going to apply the gate belt, and this just helps me transfer you safely. Okay. Okay, doing a 2-finger check, making sure the only 2 fingers fit inside of the belt. Are you feeling any discomfort?
Yeah.
Okay, so our feet are on the floor. Just going to bring this wheelchair a little closer. I'm going to part your legs just a little. And so now your arms go on my shoulders. And on the count of 3, I'm going to stand you, turn you, and sit you into the chair, okay?
Okay.
1, 2, up on 3. Turn and sit. Great job. How do you feel?
I feel good.
And so now, I'm going to put 2 feet on 1 pedal. And I don't have to lock the wheelchair. The wheelchair still moves side to side, even though the brakes are locked. If you don't feel comfortable doing that, or if your patient's heavy, you can unlock the brakes, but do place the lock back. Because for the state of Florida CNA exam, your patient's not going anywhere. They're just going to be in the wheelchair for a little bit. Okay. So here's your call bell. Is there anything that I can give you right now?
No, ma'am.
Okay, there you go. Okay. I'm opening your curtain, washing my hands, and you are done with your skill. We'll see you in the next video. This is Nurse Eunice with Florida Training Academy. Bye.
Are you getting ready for the CNA examination? If so, don't study alone. Study smarter with Nurse Eunice. That's right. At nurseeunice.com, you can download free study guides and practice tests to boost your confidence. And when you're ready to take it to the next level, grab your CNA exam prep workbook, available at booksbyeunice.com or nurseeunice.com.
Hello, everybody, and welcome back. My name is Eunice Mathis. I'm a registered nurse and the owner of Florida Training Academy. In today's video, I'm going to show you how to perform range of motion exercises to our patient's upper extremity and also lower extremity. Performing range of motion exercises is extremely important. Not only does it loosen stiff joints, it also helps to prevent atrophy or muscle wasting. Remember, if your patients don't use it, they lose it. So you want to encourage them to use their muscles to move things, siblings to actually comb their own hair and participate in their care. Additionally, something else that you may not consider is that whenever you have a person move around, it improves their circulation and they're less likely to develop blood clots. All right, so we have our wonderful patient actor here. His name is Patrick, and we're going to go ahead and begin. I've already washed my hands, provided privacy. For this skill, I will not be wearing gloves. Let's go ahead and start. All right, so I'm going to start off by exercising your shoulder. Do I have your permission to do so?
Yes.
All right, so let's go ahead and straighten out your arm. If during this process you feel any pain, just let me know. All right, so I'm going to bring your arm all the way up as far as you can tolerate. Very good. 1, 2, and 3. Very good. I'm now going to bring it out towards me. 1, 2, and 3. And next we're going to do rotations, okay? I'm going to bring it out, and I'm just going to 1, 2, 3. Great job. Did you feel any pain?
No.
All right, so I'm just going to fix your shirt just a little bit. And so now we're going to exercise your elbow. I'm going to take my supporting hand, go beneath your elbow, and we're going to do 3 curls. 1, 2, and 3. Still doing okay?
Mm-hmm.
All right, I'm going to exercise your wrist. I'm just going to gently support. I'm going to have my hand on your palm, and we're going to go down 3 times. 1, 2, 3. And for camera purposes, I'm not hyper extending, bringing the arm back or the wrist back too far. I'm just going down in a natural position 3 times. And then next, we're going to go side to side 3 times. Last will be our rotations. 1, 2, 3. So let's repeat that. Down and up 3 times, side to side 3 times, rotation 3 times. For the state of Florida examination, you do not have to exercise fingers. However, if you know that one of your residents has arthritic fingers, that could be something you can talk to the physical therapist about or the physical therapist assistant so they can show you how to relieve those stiff joints. Now we're going to go down to the lower body. So Patrick, now I'm going to exercise your leg. Right? I'm going to go under the calf and support and also under the mid thigh. And we're going to go up 3 times. Let me know if you feel any pain. 1, 2, 3. I'm now going to bring your leg towards me, the same as we did with your shoulder. 1, 2, 3. And now we're going to do our hip rotations. 1, 2, and 3. Everything okay? I'm going to exercise your knee. I'm going to put my supporting hand beneath your knee. And I'm also going to take my other hand and go under your heel. And that's going to prevent your heel from dragging. I'm going to go up 3 times. 1, 2, and 3. Still doing okay? Now we're going to exercise your ankle. Let me support your heel so it doesn't drag. We're going to go down 3 times. 1, 2, 3. We're going to go side to side the same way we did with your wrist. 1, 2, 3. And now we're going to do those rotations. 1, 2, and 3. So is it okay if I lay you down some?
Yes.
So we're going to lower the head of the bed. But we're also going to bring the bed up to a working height. Lower the side rail.